Yes, we're. It's not. Let's see.
Good morning and welcome. I think we'll start in about 30 seconds or 1 minute. So just if everyone who needs a seat can get a seat. Okay, well, it's clearly my distinct pleasure and joy really to welcome all of you, each and every one who's here in person and those of you who are joining us virtually for today's symposium. The title of our symposium is Multidisciplinary Care to Improve Melanoma Patient Outcomes. As you'll appreciate during the course of this morning, there have been many advances in the care for patients with melanoma. And today we're going to highlight, emphasize, and really put forward the essential nature of multidisciplinary care to make this happen to date and for this to keep going forward in the future. By way of brief background, melanoma remains a common cancer. These are estimates from the American Cancer Society for the current year, 2025, and about 104,960 cases, somewhat of a male to female predominance. And in terms of estimated deaths, 8,430. So again, this remains a common cancer. This remains a serious problem. Many advances have happened, but many more advances yet still need to happen for all those who have melanoma today or will get it tomorrow. So I'll just briefly walk through the agenda. So we'll start with Dr. Connie Wang, Assistant Professor in Dermatology, and she'll review and give an overview about dermatology advances in melanoma detection and surveillance. Dr. Heather Newman, Professor in Surgical Oncology, will then speak about surgical advances in melanoma. And then Dr. Vince Ma, Assistant Professor in the Division of Hematology, Medical Oncology, and Palliative Care, will talk about clinical studies to improve outcomes for advanced stage melanoma patients. I'll ask you to hold questions then, because we'll then have a Q&A following all three initial presentations and a chance to really ask questions to any of those presenters, and then a break. Afterwards, Dr. Adam Burr, Assistant Professor in Radiation Oncology, and he's in the Department of Human Oncology, will talk about novel uses of radiation therapy in melanoma. And then I'll speak about lab insights to realize a better tomorrow for melanoma patients. At the end, Ann Garst-Taylor will talk about AIM at Melanoma Patient Resources. And again, we'll have a Q&A for really any presenters over the course of the morning, and we'll take live questions and questions from our audience as well. So again, it's really with great pleasure that I open the session, and Ann will first talk about some logistics for this morning's session as well. So Ann from AIM at Melanoma, welcome to the podium.
Good morning. It is such a delight to be back in beautiful Madison. Thank you for this weather, whoever scheduled that for me. I appreciate that. What a gorgeous evening it was last night. As Dr. Albertini said, I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma. And we are absolutely delighted to be co-hosting today's symposium with the Carbone Cancer Center. I want to thank Dr. Albertini for leading the charge and serving as our moderator, and of course, all of our panelists for their collective wisdom. I'm going to get a chance later on to tell you more about AIM at Melanoma, but I just wanted to explain, as Dr. Albertini said, we're going to have two opportunities for live Q&A sessions, and I just want you to know how you're going to get a chance to ask your questions today. If you're here in the room with us, welcome everybody. This is a wonderful crowd today. You have two ways that you can ask questions. One is that we have a mic, and if you'd like, you can ask your question directly to our panelists. They'll be seated over here, and you'll have an opportunity to ask a question that way. The other way is if you look in the patient packet that we gave you, there's a little pad inside there, and if you, I hope you got a pen as well. You're welcome if you're a little shy. You're welcome to write your question down, and then I'll be standing. You can raise your hand up and I'll come get your question from you, and then I'll give it to Dr. Albertini and he can read your question for you. So it's up to you whether or not you'd like to speak on the mic or not. If you're joining us via Zoom, Facebook, or YouTube, welcome. We're so glad that you're here with us today. We know that we have about 100 people viewing from all across the United States, and you also can ask your questions live today. If you are on Zoom, if you look at the bottom of your screen, you will see a tab at the bottom that says Q&A, and that is where you put your questions, and I will get them transferred over to Dr. Albertini. And if you're on Facebook or YouTube, then you just put your questions into the comments field, and we'll pick those up that way too. So everyone will get an opportunity to ask questions today. And so with that, I'm going to give the podium to Dr. Wang so that she can start our first presentation.
Good morning. I'm Connie Wayne from, is this okay? Okay. I'm from the Department of Dermatology, and I'm really excited to share with you some of the advances in the field of dermatology related to melanoma screening. So first we have to go over a little bit of background information just so that we're on the same page, and then we'll take a cursory view at some of the newer technologies have come up over the past few years, most of which are in either imaging or other technologies. And because we're limited by time, it'll be kind of a very cursory view. So many of you probably know this already, but just so that we start on the same page, just going over a few of the definitions related to staging. So stage 0, or melanoma in situ, is melanoma that's really limited to the top layer of skin or the epidermis. It's got a very good prognosis, cured with surgery. Invasive melanoma is basically anything that is not melanoma in situ. So it's melanoma that has invaded into the dermis beyond the epidermis. And we stage it based on how thick or how deep that melanoma is. And then advanced melanoma really refers to stage 3 or 4 disease, where it's spread to the lymph nodes or to distant organs. So melanoma, as Dr. Albertini said, accounts for a significant portion of cancers in the U.S. Now, in dermatology, we see a lot of skin cancer, and melanoma actually is quite uncommon because basal cell and squamous cell carcinomas are far more common, but melanoma does account for a significant portion of the deaths related to skin cancer. It's the 6th most common cancer in the U.S., although by now it may have moved up in rank. This was data from 2019. And one of the most concerning things is that melanoma cases are rising fairly rapidly and steadily over the past few decades. And let's take a closer look at that trend here on the next slide. So as you can see on the right, incidence has been, that blue line has been increasing steadily over the past few decades. On the left, you see that this includes both invasive and melanoma in situ, although we see a slightly sharper increase in melanoma in situ cases over the past few decades. Now, if you look on the right again, mortality has actually stayed fairly constant over that time period, and even slightly decreased in the most recent few years, largely attributed to really spectacular advances in the treatment of advanced disease in the form of immunotherapy and targeted treatments. Now, given this data, some people have started to ask, is this overdiagnosis? Now, overdiagnosis means that we're diagnosing medical conditions that actually would never cause problems in the patient's lifetime. You probably have heard of this in the context of prostate cancer, where increased PSA screening led to cases of prostate cancer that really are very low grade and would have never caused problems to be diagnosed in patients who otherwise get treatments and get side effects from these treatments. So the fact that mortality has stayed so stable, despite a really significant increase in cases of melanoma, really suggests that there's probably some element of overdiagnosis. However, we really need more work to figure out which tumors are the bad actors versus which ones are the ones that would have caused no harm. So that's an ongoing field of research. So historically, there was a push for skin cancer screening in the 70s and 80s. Since then, the field really has turned towards a more like risk assessment based approach to determine how to screen and whom to screen. So why do we need to assess risk? So there are 258 million adults in the US, based on the last census in 2020. There's only 11,500 practicing dermatologists. If we were to screen every adult in the US on an annual basis, each dermatologist would have to see 22,000 patients in the course of a year, which is certainly not something that is feasible. So there are a lot of risk factors that have been identified. Certainly, we see melanoma in our older patients more often, but there's more melanoma in people who have had prior skin cancer, either melanoma or other types of skin cancer, people who have fair complexions or large numbers of moles or atypical moles. UV exposure is a big risk factor as well. Exposure to either natural sunlight, tanning beds, and getting sunburns. Occupational exposures, immunosuppression, and then finally some genetic syndromes can predispose people to have multiple melanomas. Now, risk is largely assessed clinically, but there have been tools that have been developed over the years to try to help clinicians assess risk. One of the ones that is more readily accessible was developed by the Melanoma Institute of Australia. They have a lot of melanoma cases in Australia, as you might know. And so they developed this risk assessment tool, which you can access on their website. It's meant for clinicians to use with patients, but really anyone can access it. And then it lets you enter your age, some risk factors, and it gives you predicted risk for developing a first melanoma. Now, this is for someone who's never had melanoma. They have a separate one for developing a second melanoma. So now that we've covered the background, we can move on to the new technologies. So total body photography is not exactly new. So this has been used for decades, ever since film cameras were available. We still have patients who come in with stacks of images that they've had taken over the years in a manila folder. But now we have technology that makes this a lot more feasible to obtain and save the images and compare them with the advent of digital photography. So basically, the premise is that you take photos of each area of the body, helps us keep track of the moles that are there and help monitor them. And now with technology, we can actually combine it with dermoscopy. So dermoscopy is basically using a magnifying glass with a strong polarized light to allow us to see some of the structures that otherwise are not visible to the naked eye. And there are technologies that make this a little bit easier to take photos rather than having a photographer come in and take a lot of photos. We have computer programs that can help us. So lots of technologies are out there. They range from really portable equipment to like ultra portable, where it's on a smartphone and it's connected to the cloud, to really fancy 3D scanners that are like a CT scanner and take up a whole room. So let's see how this works. So when we add dermoscopy to it, what essentially happens is at the first visit, the patient gets what we call mole mapping photos colloquially, so a photo of general body areas. Any atypical moles are identified, and then they get dermoscopy photos, so those really up-close photos. And then when the patient comes for follow-up, the photos get repeated, and then they're compared. And then ones that really have not changed over a few years are regarded as benign. And then, of course, any new lesions are picked up as well. So in clinical use, so this is an example from the literature. So this is a 23-year-old who has had prior melanoma and family history of melanoma. So he's at pretty high risk for getting others. And he was monitored for several years using this technology. You can see the photos here on top, which are the total body photography photos. And then some atypical lesions were monitored over time. So this is one on the chest, and you can see it's been fairly stable over a few years of monitoring. But then in April of 2008, it developed a small dark spot on the periphery. Patient came back for follow-up 6 months later. That small spot was darker. So at that point, the decision was made to biopsy, and the diagnosis was melanoma in situ. So this technology really allows us to see changes early, and make the diagnosis early. So that's something that we can work with. So what can we do with this technology? So the hope for the ideal scenario is that this will allow us to not biopsy so much, because we're able to monitor, really avoid biopsying things that are benign, and not miss melanomas, even ones that develop more subtly. And ideally be something that's cost effective and easy to implement and can be used widely. But unfortunately, we're not there yet. So recently, a randomized controlled trial, which is sort of the gold standard for causal relationships, in Australia, they found that when they added total body photography to usual clinical care, so coming in for regular skin exams with a dermatologist, they actually ended up doing more excisions, so more biopsies of benign things, because they actually did not find more melanomas. So essentially, the technology did more harm than good, and it did not do what we expected and hoped for it to do. So really more research is needed to figure out how best to use this technologies, really figuring out who this technology is good for and what circumstances it's useful, and then also ways to improve the technology itself, so that it is not something that harms our patients. So now we'll move on to some other methods of non-invasive imaging. So first, we'll just talk briefly about reflectance confocal microscopy. So in terms of non-invasive imaging, so currently, as many of you are probably familiar with, what happens when there's a suspicious spot is you go to the dermatologist and they'll take a biopsy, send it off to the pathologist to get a diagnosis. Now that's still the gold standard, but the goal with non-invasive imaging is maybe can we avoid biopsying so many lesions, or can we get a diagnosis even without a biopsy? So this technology, it uses the near infrared laser and it takes scans of the skin at a few different depths, and then those images are stitched together to create a 3D image. So essentially doing a virtual biopsy with light. So this is what the instrument looks like. So you can see there's a scanner that's attached, and that gets placed on the skin over a lesion. And then this is an example of what the pictures look like. So that's a lesion on the skin. It's actually a melanoma in this case. Gets scanned, and you can see all those little squares are actually individual scans that are pieced together. So as you can imagine, that's a pretty time-consuming process to image one lesion. And so this technology is really not used widely currently, because it's got quite a few limitations. So it's limited to very small spots on the skin. It can't see very deep. So really just to the upper dermis is how much this can penetrate the skin. And of course, in places where the skin is a little bit thicker, where there's hair, like the scalp or the palms and soles, it's not very useful. The equipment is pretty expensive. It takes time, so we can't really go around and photograph every single mole or suspicious lesion with this. It's really something that can be used on a few at a time. And a lot of expertise is needed to interpret those images, as you can see. Those images, the computer doesn't give you a diagnosis. It gives you those images, and of course, the quality of the images can vary quite a bit too. So the second technology that's been developed is something called multispectral imaging. Now that's used in dermatology, it's used in other fields as well. Essentially what this does is it uses different wavelengths of light to probe the skin. And the advantage of using different wavelengths is that the different wavelengths actually interact differently with structures and molecules in the skin. So it allows us to see melanin, allows us to see hemoglobin, where they are, how concentrated. And then the other advantage is that actually different wavelengths of light penetrate the skin differently. So as we saw from the reflectance confocal microscopy, if you use infrared light, it can actually see a little bit deeper into the skin than we would otherwise. So in practice, only a few machines have been commercialized. One of the earlier ones was something called Melafine. So this was FDA cleared in 2011. You can see what the device looks like on the right. It was designed for use by dermatologists to really assess pigmented lesions and see if they're melanoma. It does a pretty good job. So it has a high sensitivity, meaning that if something is a melanoma, it's a pretty good chance that this machine will tell you that it's a melanoma, sensitivity of 98%, but a very low specificity. So specificity means that if something's not melanoma, the machine will tell you correctly that it's not melanoma. So unfortunately, it's not very good at that. So it led to many biopsies of benign lesions. It really wasn't widely adopted for that reason and for many others. It's highly specialized. It is something that's quite expensive. And so in 2017, the company stopped manufacturing it. Now, the latest entry into this field is something called DermaSensor. So this was FDA approved or FDA cleared. It's a device just last year. It's actually designed for use by PCPs or primary care to assess suspicious skin lesions. And it doesn't just look for melanoma, it actually looks for more common types of skin cancer as well, such as basal cell carcinoma and squamous cell carcinoma. Again, it's a pretty good technology, high sensitivity, around 96%, and still low specificity, but a little bit better, around 20%. And you can see what the device looks like on the bottom there. Essentially, it's a smartphone with a probe. And you put it on the skin, it takes a few readings, and really within 20 seconds, it gives you a result, which is either this is something that should be biopsied or something that can be monitored. And so the jury is still out on how widely adopted this will be and how it'll perform in the real world. But it's got a few things going for it. It's a lower cost device, first of all. It's much easier to use, as you can see. It's basically something that you can keep in your pocket, more or less like your smartphone, versus a piece of costly equipment that needs to be wheeled around. And it's really doing something different. So it's reaching a wider audience. So it's being used to diagnose not just melanoma, but other types of skin cancer. Not diagnose, but to determine which ones are suspicious and need to be biopsied. And it's really increasing access to dermatology care by providing PCPs with this tool that can save patients from needing to go to the dermatologist in some cases, or at least keep some patients from needing to see the dermatologist. They don't need a biopsy. So we'll see how this performs. Probably hear more in a few years. And then I just wanted to touch briefly on AI as well. Now, you've probably seen AI in other parts of your life, but it's coming in dermatology as well. Some of the technologies we talked about, they actually already incorporate AI. So AI helps us interpret the data from all these photos, the dermoscopy, monitoring lesions over time, seeing which ones have changed. And then really the multispectral imaging is all interpreted by the computer and it spits out a result for you. But one of the interesting things in the field of AI is using AI for decision support. So not to replace your clinicians, but really to enhance their accuracy. There have been a number of studies done in this regard over the years. And what's interesting is that a lot of them found that AI is really comparable to expert dermatologists who are experienced, but it can really help increase the accuracy of primary care physicians, physician's assistants, or even trainees. So it's something that is probably coming on the horizon as the decision support tool. And then lastly, I wanted to talk a little bit about teledermatology and really access to care and how that might help in that regard. So access to dermatology, unfortunately, is limited by geography and also limited by available resources. So the number of dermatologists just that are out there and also the wait times for appointments. So this is a map showing the number of dermatologists practicing in each county of Wisconsin. It's a few years out of date, but still fairly accurate. And as you can see in red, those are the counties with no dermatologists. And then as the colors shift towards blue, that's the counties with more dermatologists, which is here in Dane County and also in the Milwaukee area. So as you can see, for a lot of people who live up north in our state, they have to drive really far to see a dermatologist, and sometimes that can be a huge barrier. So what is teledermatology? Essentially, it's using telemedicine is just using tools that we all know about, your smartphone, video conferences, the internet, to really bring medical care and education to remote places. And it can be useful in improving access in dermatology. So let's see examples of how this might work. So for someone living in a remote area, they may not have a dermatologist, but they'll have a primary care doctor who's usually close. So if they go to their primary care doctor and they have something on their skin that's growing and suspicious, the primary care doctor can take a photo of it, send it to a dermatologist who doesn't need to be in the local area, can be even in a different state for that matter. And the dermatologist can take a look at the photo and determine if a biopsy is needed. In a lot of cases, the primary care doctor can do the biopsy, so the patient can get all the care that they need without having to travel. And another example of what we use it for, so for triage. So say you find something on your skin that's suspicious, and of course we know here in our system, unfortunately, wait times are pretty long for dermatology. You can then send it to your dermatologist. They can take a look at the photo, and from the photo, they can tell you, is it something that can wait until your next visit, or is it something that they need to biopsy, in which case they can usually fit you in for a biopsy at a sooner date. So I think some of the slides have shifted a little bit, but how are we using this at UW? So we actually do offer e-visits and e-consults to patients and to specialists to be able to send these photos to us. So it's called a store and forward service, where the dermatologists then review it and then they get back with their recommendations. And it's actually expanding not just to patients in our system, but patients across the state. So Dr. Sarah Korger and Dr. Jeanette Comstock, you see their photos on the slide. They're two of our dermatologists in our department who are really championing extending teledermatology to the rest of the state, particularly in our rural areas, partnering with something called the Orion Initiative starting this year, and then also to underserved communities. And they've already partnered with the AAD dermatology program to do that. Something similar is actually happening in our VA. So our VA is actually one of the first few VAs to start teledermatology. And now they're offering services to the Toma area as well. So really extending their reach. And then one of the more exciting things is they recently added teledermatology with dermoscopy. So that's, again, that magnified photo that allows the dermatologist to make a more accurate assessment of any lesions that are photographed. And what has done, so really 10 to 30% of patients after getting a dermatology consult still need to come in. So the vast majority of patients are receiving care where they're at and in a timely manner. So I think we'll, of course, see more of teledermatology in the coming years, but it's something that's really made a lot of improvements in how we can access care to dermatologists. So basically the main takeaways. So melanoma, it's increasing in incidence. Some of it may be overdiagnosis. In terms of risk assessment, that's something that's very important to figure out who are the people that need to be screened, who are the people that are at higher risk. And then newer technologies, they offer a lot of promise in terms of increasing both the efficiency and accuracy of being able to screen and diagnose melanomas, and also improving access to care, because frankly, if we're good at what we do, but we can't do it for enough people or in a timely manner, then it's no good. So that's all I have for today. And then I would like to invite Dr. Newman to the podium.
Okay, so I'll sort of take over after what happens when there's a diagnosis. And so the things I'm going to cover is primary treatment of melanoma, management of a positive sentinel lymph node, and then talk a little bit about the multidisciplinary approach we're taking for some of our locally advanced melanomas. So I have a case presentation that'll go all the way through. So this is a 55-year-old female who presents with a changing mole on her back. She was biopsied by her dermatologist. It showed melanoma, a Breslow thickness of 2.0. This is an intermediate thickness melanoma with no ulceration. And she was referred to surgery for management. And so wide local excision always is a part of that treatment. It's the piece that really minimizes that local recurrence. But the question is really, how wide does wide need to be? And so, back before I was practicing, wide really meant 4 centimeter margins, which you can imagine if you look at that popsicle stick, that's over half of the popsicle stick as a divot in somebody's skin. There was a number of studies that looked at either 1 versus 3, 2 versus 4 centimeter margins. And the one that I highlighted here is the US study, which is the intergroup melanoma surgical trial. That compared 2 versus 4 centimeter margins. And what we can see on the screen, this is the rate of local recurrence between the two arms, which are essentially the same. And this was one example of the trials that demonstrated those wider margins of 4 centimeters aren't really necessary. And so 2 centimeter margins became the standard for most of our patients. The thing that's hard is that 2 centimeter margins, depending on where it is on the body, can still be tricky to close. So this is an example of someone who was closed with an ellipse, so kind of like that football shape incision that's pulled together. You can see that scars widen. There's kind of those railroad scars. I mean, that is probably our best case. Up to a third of people end up with some sort of local rotational flap or a skin graft to get it to close. And as you get more complicated, there's a higher risk of wound complications. So this question of whether we really need to even have 2 centimeter margins is being addressed in the MELMART 2 study, which is an ongoing clinical trial which took patients who have intermediate thickness melanoma, so those patients for who 2 centimeter margins is the standard, and are randomizing them to get 1 centimeter margin versus 2. The primary outcome is 5-year disease-free survival. This includes both local recurrence, distant recurrence, all sort of melanoma events. They're also looking at specifically local recurrence, overall survival, quality of life, and surgical complications. This study has either completed accrual or almost completed accrual, and we have an estimated primary completion date of the end of 2029. So we need that 5-year outcome data, so it takes a little bit of time. I think this study is a really good example of a trial that has the potential to absolutely impact what our standard of care is. So everyone in this red are the people who currently get 2 centimeter margins. So depending on the results of the study, we could change what we're offering for care for probably a substantial portion of our patients with melanoma. So to continue our case presentation, she did meet with the surgeon, planned the 2 centimeter margin, which is the current norm. The lymph nodes were examined clinically. They all looked normal. And so the question is a clinical exam enough, or do we need to look more? And that's really where we talk about the sentinel lymph node biopsy. The idea is that even if the lymph nodes feel normal, there's always a chance that there's something microscopic there. When we do the sentinel lymph node, we inject a radioactive tracer or blue dye right around the site of the biopsy. Those dyes get taken up into the lymphatics, and they travel to the first lymph nodes that area of the skin would drain to. If the melanoma was going to spread, that's the same pathway it would take. These are the lymph nodes that would be most at risk. We have a handheld kind of Geiger counter. We look for anything that's hot, anything that's blue, and we take those out. So those are the sentinel lymph nodes. And when we think about why those matter, the first is that it's really prognostic. So if you have something in the sentinel lymph node, you're at much higher risk of having a future melanoma event than if that lymph node is clear. When we find something and we know that someone's at higher risk, that's when we start to think about doing more imaging. It changes our surveillance. It changes kind of whether we get PET CT or CT, kind of whole body imaging. It's also when we start to think about other treatments, so things like immunotherapy that we'll talk about in the later sessions. Historically, the sentinel lymph nodes are those first lymph nodes that drain from the melanoma or from the primary skin site, but it doesn't tell us anything about the rest of the lymph nodes in that lymph node basin. And so historically, the only way we could find out if there's anything else in that lymph node basin is to do a full lymph node surgery. And by far the benefit is that we know with confidence that if there's anything else in that lymph node basin, we've taken it out. There's obviously some downsides. So almost always it's a second surgery, more discomfort. There's drains that are in place. range of motion that we have to work on, but lymphedema is really the thing that we worry about most. And that's probably 20 to 40%, depending on whether it's neck or armpit or groin. So the MSLT2 clinical trial really was trying to address this question of, do we need to do the completion lymph node dissection for everybody? They took patients that had a positive sentinel lymph node, so people who we found the lymph node and there was a little spot of melanoma in it, and then those patients got randomized to either the completion lymph node dissection or this extra close observation. And that's with not just clinical exams, but using ultrasounds. So this is an example of what a normal lymph node looks like by ultrasound. So kind of has a little kidney bean shape. That black part is the outer cortex. Inside that circle, that's the fatty hilum. This is what a normal lymph node looks like. And the idea is that when there's any melanoma in a lymph node, that morphology, that architecture will change long before you can feel it clinically. And this is just an example of a lymph node that did have cancer in it, where that cortex starts to get much thicker. It doesn't quite have that kidney bean shape anymore. It's starting to get more rounded. And these are the kinds of things that we're looking for when we're doing the serial ultrasounds to say, hey, this is someone who maybe we should biopsy it. Maybe this is someone who has melanoma in that lymph node basin. So the MSLT2 study compared those two arms, people who had surgery right away and people who only had surgery if something progressed. And at their 10-year outcome, there was no difference in survival. And I think probably one of the things that I talk the most about is that 75% of people in that observation arm never ended up needing that lymph node surgery. So they were spared all the morbidity of what happens with the lymph node dissection because they never had anything developed there. The 25% of people who ended up having something progress and went on to have that lymph node surgery, I think we can have confidence that we're not hurting them oncologically. Like the cancer outcomes are the same as if we had done it up front. So I think this was a really big advance and is really reflected in our current standards. You know, looking at patients who have sentinel lymph node positive disease, the NCCN guidelines absolutely recommend active nodal basin ultrasound or other sort of imaging surveillance as the standard as opposed to completion dissections for everybody up front. So to continue our case presentation, she had a wide local excision, had the 2-centimeter margins, had a sentinel lymph node biopsy, which was found to be positive, and was followed with MSLT2 surveillance, as well as some systemic imaging. And on one of those PET CTs, she was found to have a new lump on her back, so just kind of lateral to where the primary excision had been. And you can see it, that's that bright spot on the PET imaging. This was biopsied and confirmed to be melanoma. In this spot, this is something we can resect surgically. It's just there in the skin. There's lots of extra tissue there. But the question is whether surgery first is the right thing to be doing. And I think the things I've talked about so far have absolutely changed our clinical practice. In the last year and a half, this has probably been the biggest change for me as a surgeon when I'm seeing patients. And it really comes down to what is the role for neoadjuvant therapy for patients with melanoma. So I'm going to not look at Dr. Albertini and Dr. Ma as I explain the surgeon's view of immunotherapy. But the way I think about it is that melanoma is able to turn off the immune system right around it so that the immune system can't find it. And it does it because it doesn't allow certain things to bind, things like that. What the immunotherapies functionally do is they come in and they turn off that off switch. So now that the T cells, the immune system can start to be activated and fight the melanoma. The rationale about neoadjuvant therapy, as opposed to only, that's treatment before surgery, as opposed to only treatment after, is that if you get that immune system activated while the melanoma is still there, the immune system has a better chance of figuring out what it's supposed to be fighting. And then maybe it's going to do a better job even after you remove it. So that's exactly what happened. And these are 2 studies that were published in the New England Journal. And so we can imagine anything published in the New England Journal means that this is going to be a big change in what we do. And they both looked at patients who got immunotherapy first, followed by surgery, plus or minus more immunotherapy after, versus surgery first and the same amount of immunotherapy after. The blue lines here are people who had neoadjuvant therapy. The red lines are the only immunotherapy after surgery, and you can see there's a marked difference in outcomes for patients who got the immunotherapy first. This has dramatically changed how we think about patients who come in with a spot like our case presentation, something that's surgically resectable, but maybe not as the first step. So just a summary of what I talked about. I'm really excited about where we are with melanoma surgery because we're starting to think about how do we reduce the morbidity of what we do while making sure we still have good oncologic outcomes. So both MELMART2 and MSLT2 exactly do that. They help to reduce the morbidity while making sure that we're not compromising any of our treatment. And we're really starting to leverage the innovations that we're seeing in systemic therapy and immunotherapy to optimize outcomes. So melanoma for the longest time was cut out anything you see always. And that's not where we are now. We're starting to really benefit from the systemic therapy advances and now starting to figure out how to sequence them to make sure that we're optimizing both the surgery and those systemic therapy pieces. I'm showing one picture from my recent vacation to remind you that even though you're all here this morning, it's really lovely outside. This is going to be a beautiful weekend. So I will pass this off to Dr. Ma, who's going to talk about some of the clinical studies that has helped with what I've talked about.
Great. So thank you for having me this morning. It was an excellent talk from Dr. Wang and Dr. Newman. And so just to introduce myself, my name is Dr. Vince Ma, and I'm a medical oncologist here at the UW Carbone. And today I'm very pleased to be able to talk a little bit about some of the exciting clinical studies on actually improving outcomes of patients with advanced stage melanoma. These are my disclosures. And so as a medical oncologist, I primarily see patients in my clinic with advanced stage melanoma. And so the history for many of these patients are usually where they're diagnosed with melanoma, primarily a skin melanoma in the distant past. And unfortunately, despite excellent efforts by surveillance from dermatologists as well as surgery, we know that a proportion of these patients unfortunately go on to develop advanced stage disease or metastatic or stage 4 melanoma. And so oftentimes when I see patients in clinic with a new diagnosis of stage 4 or metastatic disease, I oftentimes like to give a very brief history lesson about this disease. Say if you were to see me back in the early 2000s, where at that time we really did not have much in terms of systemic treatment options. Really, the median overall survival was around 6 months. At that time, we really used things like chemotherapy and really has not been shown to be that efficacious for treatment of the disease. And so nowadays, if you look at what we have now, since 2011, we've had an explosion of different systemic therapy options now to really treat our patients with metastatic disease. Starting off with ipilimumab, also known as Yervoy. We have since then developed dual agent immunotherapy. We've also approved targeted therapy as well for patients who have a BRAF mutation. And then more recently, this past year, we got FDA approval of lifileucel, also known as TIL therapy, to treat patients with advanced stage melanoma. And so with this success that we've seen so far, what was thought to be unimaginable, a patient with stage 4 melanoma can literally have their disease nearly melt away. And we might even be thinking about, for some of these patients, we could potentially be curing some of them as well. What was recently published this past year was a 10-year follow-up data of patients who were treated with combination immunotherapy, specifically nivolumab plus ipilimumab, also known as Opdivo and Yervoy. And what they found was that the patients studied in this particular trial, after 10 years of follow-up, that we saw that about half of these patients were even alive. So such an unprecedented period of time that we're seeing now with patients who have this stage 4 or advanced disease. And with this success, we're also seeing a decrease in mortality over the past several years. Now, what I really wanted to emphasize here is that while we've seen a lot of great success with this treatment, we know that a good proportion of these patients that despite our excellent efforts to do things like surgery, radiation, and a variety of systemic treatment options, we know that a good proportion of these patients still unfortunately do not benefit or develop resistance to some of the treatments that I've mentioned as well. And so, as you can imagine, lots of very smart scientists out there are looking at just so many different pathways, different targets, different ways to help reinvigorate the immune system, lift the brakes off the immune system to better enhance the therapies for especially those patients who are resistant to some of the treatment options that we have available. And I know that with this illustration here, quite a lot being studied, but as you can imagine, lots of work still needs to be done, particularly in this space. One particular therapy that I really wanted to discuss today is actually about TIL therapy, or tumor infiltrating lymphocyte therapy. It's also known as lifileucel, or the brand name is Amtagvi. As I mentioned earlier, this was FDA approved in February 2024. And this is a first in its kind cellular therapy that was approved first in a solid cancer. And of course, it had to be melanoma. Now, cellular therapy has been investigated and it's been approved in other disease types, particularly lymphoma, but this is the first in a solid cancer. It is a type of cellular therapy treatment, and it is a single one-time treatment. And ideally, this particular therapy is used for patients who have previously received or progressed on immunotherapy or targeted therapy if the patients have a BRAF mutation of their tumor. This particular therapy is quite complex and is only available in select cancer centers, and we hope that by the end of this year, we'll have this treatment available here at the University of Wisconsin. So I'd like to walk through with you all just a little bit about how TIL therapy works, because this is a pretty novel therapy treatment, and it's not quite as simple as giving a drug that's an IV that you get through your vein or a treatment that you take by pill. So just to walk you through it a little bit, so you have a patient on the top left who has advanced stage melanoma, who has progressed on immunotherapy or targeted therapy. If there is a tumor that is large enough, that patient then undergoes surgery to remove one of those tumors. That tumor there, we're looking at specifically the TIL, or the tumor infiltrating lymphocytes. These are essentially these white blood cells that are attacking or attempting to attack the melanoma tumor. And what you're hoping to do is that you want to expand upon that even further. You want to grow that in a lab. And so what you do is that you submit these TIL centrally to a company that then it grows it and expands it even further. And it takes several weeks for this to occur. Now, after that, it then gets shipped back to the institution that did the surgery, and you essentially bag it up and keep it frozen until you're ready to use it. Now, part 2 of this TIL therapy requires that the patient then has to undergo chemotherapy. And this chemotherapy is not intended to treat the melanoma itself, but to actually wipe out the immune system so you can accommodate the TIL therapy. Following the chemotherapy, the TIL is then infused into the patient, and subsequent to that, the patients then actually get hospitalized, where they're then getting a very potent type of immunotherapy treatment called high-dose interleukin-2. High-dose interleukin-2 is a type of treatment. It's an immunotherapy type of treatment, which essentially helps to expand the TIL even further within the body. And it causes a great deal of inflammation in the body, and so patients actually have to be hospitalized for monitoring as well as treatment of side effects. Sometimes patients actually have to be hospitalized, sometimes for several days, even for weeks as well. So let's talk a little bit about the success of TIL therapy, right? So this is what we call a waterfall plot. So what this is intended to illustrate is sort of the tumor shrinkage or the cancer shrinkage that we can see for patients getting a particular treatment. So if you see that horizontal line there, right at 0, that is the baseline. Each individual bar represents a patient who got TIL therapy in this particular trial. And what you want to see is you want to see that bar go below 0 because that represents tumor or cancer shrinkage. So you're looking for the best tumor shrinkage. And so what you can see here is that a majority of the patients actually had tumor shrinkage with TIL therapy. About 79% of patients in the trial had tumor shrinkage. And if you look at that 30% dotted line there, that sort of represents the most meaningful tumor reduction that we consider in oncology, a meaningful response. And we can see that about 31% of those patients had a meaningful 30% reduction in their tumor with this particular therapy. And so I have here some illustrations of how powerful and how great TIL therapy could work for some patients. And so if you see in the far left, a patient who, prior to having TIL, had disease in their skin. And about 3 weeks later after TIL, you can see some tumor shrinkage. And as far as 12 weeks after TIL therapy, you can see that almost an ongoing response to the particular treatment. What we've learned from the trials, particularly what was presented at ASCO this year, which is an international oncology conference, we know that for patients who achieve a meaningful response to TIL therapy, that they can have what we call durable benefit. And what that means is that they can have long-lasting disease control long after their TIL infusion. Now, some of the disadvantages or some of the cons associated with TIL therapy are some of the side effects. So as you can imagine, as we're giving patients things like chemotherapy, we can see things like low blood counts, low white blood cells, low red blood cells, low platelets, in which case they may need things like transfusions. Patients can also get fevers, chills, diarrhea, low blood pressure, and even risk of infection as they're getting the treatments such as chemo or the high-dose interleukin-2. We know that some patients can unfortunately die from this treatment as well because of the potent inflammation that you get from the high-dose interleukin-2, but also the chemotherapy that can also induce or cause infection. Now, we also know that TIL is not necessarily right for everyone. This is a relatively new therapy that's been in the making for the past 40 years, and there still needs to be some work done as well. But what we know for TIL is that it's ideal for patients, or for patients who are ideally fit enough to get this particular therapy. For patients who don't have a large enough tumor, they're unfortunately not eligible for TIL because you have to do surgical harvesting to isolate the TIL. Some patients, unfortunately, just don't have sufficient TIL quality in order to get this therapy. Other patients, for example, who are on active immunosuppression or those who have rapidly growing disease, unfortunately, are not great candidates. And as of right now, there are some studies looking into whether or not TIL can be done for patients who have ocular melanoma origins, so melanoma that originates in the back of the eye. As of right now, it's not FDA approved for that indication, but it is being studied. And we also are trying to look in whether or not TIL could potentially be something that we can offer to patients who have active cancer in the brain. And so as of right now, we can't do TIL therapy if there's active brain metastases that's progressing. So just to kind of highlight the schema, as you can imagine, there's very many avenues that we can sort of explore to make TIL therapy hopefully a lot easier for some patients and hopefully more accessible to more patients as well. And so in particular, there are several studies, as you can imagine, to see how we can make TIL therapy a lot easier and more accessible. One particular study called the AGNI-01 trial, which is a phase 1/2 study looking at the role of OBX-115. This is another novel cellular therapy that's being investigated in a clinical trial right now. And so how is this a little bit different is that the TIL itself is actually engineered specifically to express a particular protein called membrane-bound interleukin-15. And so what's a little bit different is that when the TIL is extracted, these cells or these TILs are then engineered with a virus to help express those proteins. And what makes it very unique is that rather than subjecting the patients to high-dose interleukin-2 in order to expand the TIL in the body to work, you can see here that rather than using high-dose interleukin-2, we can use something called acetazolamide, which is far more well tolerated. By giving this particular medicine, you can actually help expand the TIL a lot easier. And how it does that is by actually activating the interleukin-15 that was engineered right into the actual TIL itself. And so what is some of the success we've seen so far in the earlier phases of the study? You can see here, for example, a patient who got this OBX-115, and you can see some great tumor shrinkage as well. Now, one of the limitations, particularly for this study, is it's only studied in about 17 patients, at least what's been reported so far. And what we've seen is comparable numbers to what we've seen with the standard TIL therapy. So tumor shrinkage rate at about 73%, and greater than 30% tumor reduction in about 36% of the patients treated with this therapy. So a lot of great promise with this new cellular therapy option for the future. Another type of trial or study that's also being investigated as well is another type of cellular therapy treatment. So as I kind of mentioned earlier, right, with TIL, we oftentimes think about doing surgery. Well, there's an alternative approach to doing this as well. So one of the studies here in particular called the IMA 203 phase 1 study is looking at the role of a new cellular therapy treatment option called IMA 203 PRAME. And so this is designed to essentially help enhance cellular therapy that attacks a protein that is very prevalent in melanoma, in patients with melanoma tumors, which is called PRAME. And so in order to be eligible for this particular treatment, patients have to undergo a blood testing to see if they carry this immune signature called HLA-0201. And if they're positive, they could potentially be eligible for this potential treatment. Rather than undergoing surgery, the patients then have a procedure called leukapheresis, where we're extracting the immune cells from the patient, so not subjecting patients to surgery. And it takes far less time to grow these infiltrating lymphocytes or the cellular therapy in the lab. And so by the time the IMA 203 is manufactured, this can then be ready to be administered to the patients. Now, of course, for this particular therapy, patients still need to undergo chemotherapy to wipe out their immune system. But one of the nice advantages, particularly for this IMA 203 drug that is still being under investigation, is that we actually don't use very high doses of interleukin-2. So you have hopefully far fewer side effects and hopefully better tolerability for some patients. This is a waterfall plot, and as you can see here, fewer patients than what we saw with the TIL therapy, but a lot of promise from what we can tell so far. In terms of the tumor shrinkage, greater than 30%, we saw this in more than half the patients who got treated with this novel treatment. And as of right now, this study has entered a phase 3 setting and is available in select cancer centers throughout the United States. Shifting gears a little bit, I want to talk to you all a little bit about oncolytic virus therapy, which is a new type of therapy that has really entered the field of melanoma therapy over the last several years. Now, oncolytic virus therapy is not completely new. We actually have one that is currently FDA approved right now for advanced stage melanoma called T-VEC, or the brand name is Imlygic. This particular therapy is FDA approved back in 2015, and it is an oncolytic virus therapy. And so what this really refers to is that you're injecting an engineered virus that hopefully as you inject it in the tumor can help get the immune system to better attack and hopefully clear the tumor on the body. Now, as of right now, Imlygic or T-VEC is only appropriate for patients who have disease that is primarily confined to the skin or to the lymph node, for which surgery is not an ideal option. This particular therapy is only available in select cancer centers and is typically administered by surgeons and dermatologists. And here at the University of Wisconsin, this is an option that we can actually offer and is actually done and performed by Dr. Nolen. So what is some of the success we've seen, for example, for T-VEC therapy? Well, you can see here an illustration of a patient who has a cutaneous or skin tumor of melanoma that was injected and treated with T-VEC. And you can see a lot of great success for this particular therapy. Now, as we kind of explore sort of newer generations of oncolytic virus therapy, there is one that has really entered sort of the space and probably a lot of like the marketing that we've seen so far, which is a drug called RP1, which is an engineered version of the herpes simplex virus. And so this new drug called RP1 has been studied in a clinical trial called the IGNITE trial, a phase 2/3 study, which is combined with a treatment called nivolumab, also known as Opdivo, already FDA approved. But by combining these two, this particular treatment was investigated in patients who have previously been treated with immunotherapy and targeted therapy. And one of the nice advantages of this particular treatment is that you can inject this not only in the skin, but also in tumors that are actually within or deep inside the body. So places like, for example, the liver. Similar to T-VEC, this is a treatment that can be given once every 2 weeks, only for a finite period of time while you continue the nivolumab. But as of right now, this treatment is not FDA approved. But some of the success we've seen, particularly for this particular treatment, is that if you look at this figure here, this patient on the top left who had an injection of the tumor directly into the forehead, we saw that it can actually induce an immune response and actually treat other tumors that are also not injected. And so you can see here that even by inducing or injecting one tumor in one area, you can see tumor shrinkage in areas like, for example, the liver or even the lymph nodes inside the chest. Some of the success we've seen so far, patients who have had greater than 30% reduction of the tumor, we saw that about a third of those patients had achieved that benefit. We also saw tumor shrinkage as well in non-injected tumors as well, in about 20% of patients treated with this particular therapy. I will also mention that there was a recent submission to get this treatment FDA approved last month, but unfortunately it was not granted. So what are some of the future studies that we're also thinking about, particularly for oncolytic virus therapy? As I mentioned, RP1 has been investigated, has been submitted for FDA approval, and there's ongoing right now meetings to kind of consider or reconsider getting that drug approved. But there are also newer generations of these oncolytic virus therapy. One in particular is called RP2. And RP2 right now is actually being investigated in combination with nivolumab or Opdivo. And in this particular case is being investigated in patients who have metastatic ocular melanoma. And there's a particular trial that we actually have ongoing and opened here at the University of Wisconsin. So a lot of great excitement that we're seeing right now with oncolytic viruses, oncolytic virus therapies, and there's many more being investigated as well. Now, I know the purpose of my talk today was to talk a little bit about, treatment of advanced stage melanoma, but, one of the best ways to treat advanced stage melanoma is to actually help prevent that from happening. And so no greater topic is there to talk about than to talk a little bit about cancer vaccine. So as you can imagine, vaccines have been well studied, particularly in the cancer space, for many, many years. And while we've seen a lot of success in getting the immune response to work, we have not seen much in terms of clinical benefit so far, until more recently, where we've really learned to understand that developing a vaccine that is not necessarily specific to tumor itself, but actually specific to the patient's unique particular tumor and their gene signature is probably what's going to be the most relevant in terms of inducing an immune response and helping patients to prevent melanoma from recurring. And so we're really entering the era of actually developing personalized medicine, going back into the patient's actual tumor itself, identifying the genes that are relevant, and developing an actual vaccine. And so this, as you can imagine, has the potential, particularly for patients who have been diagnosed with melanoma and had a successful surgery. How can we better prevent melanoma from coming back? A lot of publicity, particularly about the vaccine therapy, and more specifically, if you haven't seen it on the news, particularly the mRNA vaccine in melanoma. There's been a lot of talk and a lot of excitement about this new technology being developed in order to help melanoma from returning. This mRNA vaccine, which has kind of been renamed at this point as individualized neoantigen therapy, is a novel technique where we actually have to go back into the patient's originally excised or surgically removed tumor. You're identifying specific gene mutation signatures of the cancer itself, and you're identifying up to 34 specific genes. You then develop an actual mRNA vaccine based on that, and it's very individualized to the patient themselves, and you inject that as a vaccine for the patient. This has actually been first studied in melanoma, and a phase 2 comparison study was actually conducted in patients who had resected stage 3-4 melanoma and then received either pembrolizumab or Keytruda, which is a standard of care option after surgery to prevent melanoma recurrence, or they received pembrolizumab plus this individualized neoantigen therapy. And what they saw with this comparison was that the combined approach, combining immunotherapy with this vaccine, seemed to suggest that it may actually prevent recurrence than the standard immunotherapy treatment by itself. A lot of excitement with this, and as you can imagine, they moved this on to a phase 3 study, which actually just completed accrual this past year. And so by 2026 to 2027, we may be seeing some results of this. And if successful, this could be another treatment option for patients to actually help prevent recurrence of melanoma after successful surgery. Overall, key takeaways from my talk: as you can imagine, there's an unmet need for treatment options who have advanced stage melanoma, who have progressed on immunotherapy and targeted therapy. TIL therapy is currently FDA approved, but is only available for select patients who are fit enough and have great candidacy for this treatment. But there's ongoing novel clinical trials right now trying to enhance it and make it more accessible for patients. Oncolytic virus therapy has also entered the field again and is now being redeveloped in novel ways to become more accessible, particularly for patients who may not be candidates for TIL. And then patient-specific cancer vaccine therapy is also being studied right now to help prevent melanoma from returning after surgery. I appreciate and thank you for your attention, and I believe we'll be moving on to the Q&A section next.
Panelists are going to move over here for the Q&A session. If you have a question, you may either ask it directly to the microphone, or you may write your question down, raise your hand up, and I'll run over and grab it from you. But in the meantime, they have a few questions that have come in from the internet that can get us started.
Yeah, so I'll get us started with a few from the internet. First of all, just give my appreciation for, I think, 3 wonderful talks, both dermatology, surgical oncology, and medical oncology. So I'll just start with a few from online to get us started and then open it up to the people who are here. The first: why would immunotherapy be suggested for stage 2 if margins were clear? If only preventive, what about balancing with the risk of side effects? Any concerns? I guess that's a Dr. Ma question.
So, sorry, Dr. Albertini, can you repeat that question again?
Certainly. Why would immunotherapy be suggested for stage 2 if margins were clear? If only preventative, what about balancing that with the side effects? Are there any concerns?
Yeah, that's a great question. So, we know that for some patients with high risk stage 2, that even after successful surgery, that there is a risk that melanoma can recur or even progress into even stage 4 melanoma. And so the idea behind that is, with stage 2, even though the disease was just confined to the skin, we know that there are some cases where even micrometastases can enter the bloodstream or even the lymphatic channels. And so really the concept and the idea behind giving immunotherapy as a preventative action is really there to prevent the melanoma from entering or becoming a stage 3 or stage 4 melanoma. Now, of course, that risk is certainly much lower than, say, a stage 3. And so oftentimes as a medical oncologist, I'm discussing with patients sort of the pros and cons of doing adjuvant immunotherapy. We know that some patients may never have recurrence after a successful resection of stage 2, but sometimes patients would be willing to take even that slight risk of side effects with immunotherapy. So oftentimes I weigh sort of the pros and cons. Is the success of hopefully giving immunotherapy to prevent recurrence worth it? We know that with immunotherapy that sometimes people can get even long-term or even permanent side effects from immunotherapy. And oftentimes it's important that when you're diagnosed with a high-risk stage 2 melanoma, that you have these very meaningful discussions with your provider, your oncologist, about what is the risk and the benefit of getting immunotherapy as a preventative or adjuvant setting.
And one more question for Dr. Ma before we open it up to the audience here as well. And I think he'll give a so-called dream-seeking answer to this. But anyways, the question is there a standard first choice for immunotherapy for a stage 4 patient, or a standard first choice for therapy and a standard first choice for immunotherapy for stage 4 patients?
Yeah, so great question. So, over the years, we've learned that dual immunotherapy treatment is considered now the sort of the standard of care. So as I mentioned earlier in my presentation, for example, nivolumab plus ipilimumab or Opdivo and Yervoy, that is considered one option that we often consider in the first-line setting. Another option is nivolumab and relatlimab, also known as Opdualag. And so what we've seen in some of the studies so far is that dual agent immunotherapy seems to have a more favorable outcome in terms of a progression-free survival and overall survival compared to just a single agent immunotherapy treatment. Now, of course, when we think about using dual immunotherapy treatment, as you can imagine, more side effects, right? And so dual immunotherapy treatment may not be right for some individuals, particularly if we're concerned for things like side effects. For patients who, for example, have a history of a kidney transplant or patients who have a severe autoimmune history, it may not make much sense to actually do dual immunotherapy treatment. And so it's really on a case-by-case basis about choosing dual agents versus single agent immunotherapy. The other thing that often comes up as well is for patients who have a BRAF mutation on their tumor. Do I do a BRAF MEK targeted therapy or do I do immunotherapy first? And one major presentation or publication that was done over the last couple of years or so was that we found that immunotherapy should ideally be used first over targeted therapy. We've seen that patients who get started with immunotherapy first tend to have much better overall survival outcomes. And again, this is particularly for patients who are newly diagnosed with stage 4 melanoma.
Okay, I've got more questions here, but first I want to open it up to the audience. So if you would just mention your question and the presenter for whom it's most appropriate, if you don't mind saying the question for purposes of people who are watching us virtually so they can make sure they can hear it as well. So from the audience, any questions? And you can either hand in your questions or we do have a microphone that we could pass out to people as well, so.
So the question is SPF 30 good or should I use SPF 50? So that's a great question. So SPF, really, the higher the number, it's just really how much more protection it offers for your skin. But with sunscreen, really, the two most important things is one, you want to use enough of it because if you don't use enough of it, it's actually not achieving the SPF that's on the package. And then the other thing is you want to make sure you reapply because regardless of what the SPF is, sunscreen does wear off, especially if you're out doing activities that cause sweating or if you're in the water. So regardless of what the SPF is, it does wear off. Now, in terms of the number, SPF 30 is good. SPF 50 is better. Anything above 50, really, you don't need. The other things to look for is you want something that's broad spectrum. It'll say that on the bottle. Protects you against UVB and UVA. And then you also want to use other measures. So things like a wide brim hat, sun protect clothing that can protect your skin as well, in addition to sunscreen.
Other questions from the audience? Yes, in the back.
Hi, I'm Cheryl from Platteville, and my question is, I've had basal cell, squamous cell, and melanoma, and I have surveillance every 3 months. If I was and I'm 5 years out of the melanoma. If I was your patient, what would you tell me to do at this point? Besides the surveillance every 3 months, what could you recommend to me? Because I feel like I'm a ticking time bomb, basically just waiting and waiting and waiting. Thank you.
So that's a great question. In terms of what can we do, I assume, to prevent further skin cancers at this point. Um,
It was stage 1. I forgot
Stage
to
one,
mention
yeah.
that.
So with melanoma and non-melanoma skin cancer, sort of it's two different categories, if you will, even though they share some of the same risk factors. So when it comes to melanoma, really, there's not really a form of chemo prevention, so something that you can take that's been found to be effective. Now, there's ongoing research in that field. And with both, a lot of the risk factors, unfortunately, are accumulated in youth. So sun exposure earlier in life, and those are things that we cannot do anything about. But some of the risk factors that we mentioned, as you saw, so like immunosuppression for people who are immunosuppressed, maybe decreasing some of that if possible. If they're taking medications that are immunosuppressive, can be helpful in that regard.
Now, when it comes to non-melanoma skin cancer, really there have been some studies on the use of various agents that are taken orally to help prevent some of those. One is niacinamide, which is a supplement that's available over the counter, provides a modest reduction. And then the other one is something called acitretin, which is a prescription medication that does require monitoring and needs to be prescribed. So those are some of the things that are out there.
Other questions from the audience? Yes. We've got a phenomenal tag team system here. It's a multidisciplinary lecture. Have budget cuts on the federal level affected melanoma research at the UW? I don't know who wants to take that one. I'm not sitting with the panel today, so or I will be later, but anyways, Dr. Newman.
I mean, I suspect as of like now, they may not have trickled down yet, but looking forward, I will say things don't look exceptionally positive. I think it kind of depends on where the grant cycle is, but I think thinking about the NCI, which is where a lot of the big program funding comes from, the cooperative groups, which runs the big clinical trials, they're all facing budget cuts as they go into their grant renewals to get their core grants funded. I think the NCI has put out that for large studies like R01 studies, which is where, you know, a PI writes a big 4 or 5 year grant. Previously, they would fund the top 10% of grants. Now they're going to fund the top 4%. So I think looking forward, getting new research funding, it's going to be tricky. I think they're going to be faced with making decisions. Do we fund grants on like care delivery? Do we fund grants on prevention? Do we fund training and education grants from this dwindling pot of money? So I guess my answer, and this would be a great question for Dr. Albertini, who has a basic science lab, is I think probably right this minute, that trickle down effect probably hasn't happened, but I think everyone is planning for it because I think it's inevitable.
Thank you. Yes, I guess I'll add to that as well. So it unfortunately has had a major effect at the earlier stage, the earlier part of the pathway. And I think that's going to unfortunately have a major impact downstream. So at the clinical level, not yet, but at the more basic level, I think one of the primary issues is the increasingly lower pay line. So again, you look at phenomenal laboratories, phenomenal research, amazing ideas, but no funding for it. And then you get even less funding for it. So again, the experiments that will not happen are unfortunately going to impact the patient who gets melanoma tomorrow. A practical thing, and actually I haven't given my lecture yet, but I'll talk about some work I'm doing with so-called pet dogs. And again, we're trying to actually help pet dogs. These are not mill dogs. These are pet dogs where owners are incredibly trying to help their dog that gets spontaneous melanoma. And we're trying to learn basically, how can we learn from this animal that we're trying to help and then help our patients in the clinic. But there's actually now legislation that makes it illegal to use new dollars from the VA for sensitive species defined as cats, dogs, non-human primates at the end of September. And actually, I was working with pet dogs trying to help their dogs not die. That program got stopped. So again, this has had an impact both at the UW. I spoke specifically there about funds using from the Veterans Administration based on legislation. But again, across the board, we're seeing increasingly lower pay lines. We're going to have patients die in a few years because of experiments not done tomorrow. Next question.
Hi there. I just have a follow-up to my lengthy question from before. What kind of labs could I ask my provider to do every quarter, every visit that I have with them? Are there any labs that are basically recommended, or, I could ask and not feel like, I'm being denied to have those labs done? Thank you.
Yeah, sorry. So there's no laboratory monitoring when it relates to monitoring for skin cancer. It's more if you happen to be on the medication, acitretin, they would monitor your labs to make sure you're not having side effects. To clarify.
I'll also answer that question as well, because I mean, I will also mention that, more recently, if many of you have not heard about it, but the idea of using something called circulating tumor DNA, that's actually an area of ongoing research right now, which is where we can actually monitor a patient's blood to see if we can detect microscopic levels of the cancer DNA within their blood. Now, specifically for circulating tumor DNA, some of the ones that have entered more of the commercial side or entered the market, these actually are specific to the patient's tumor. So you actually have to go back to the patient's tumor that was cut out, look at the gene signature, and is very personalized for the patient. Now, I'll mention that it is still an area of ongoing research that, more recently we published over the last couple of years or so that using things like circulating tumor DNA is not necessarily 100% sensitive. And so while we think the idea of trying to detect microscopic DNA or cancer recurrence in the blood seems like a fantastic idea, the technology has not been fully enhanced yet and not fully validated. So as of right now, using things like ctDNA, circulating tumor DNA as a means for surveillance is still an area of ongoing research. And there are many studies right now trying to investigate that even further.
Okay, this question that just came in, if you have received 5 infusions of nivolumab after surgery for stage 4 and have developed pneumonitis, what what other treatment might you be offered? It's probably a Dr. Ma question.
Yeah, so pneumonitis is unfortunately a very challenging toxicity associated with immunotherapy. As you can imagine, pneumonitis, just to clarify, is basically inflammation of the lungs, which unfortunately doesn't happen quite often with immunotherapy, but it can happen in some patients. Now, the thing we worry quite a lot about, especially with pneumonitis, is that it can cause respiratory failure. And oftentimes, as a medical oncologist, I'm frequently very hesitant to re-challenge or re-administer more immunotherapy after getting pneumonitis. And so really it depends on a case-by-case basis. We sort of grade toxicities or side effects anywhere from like grade 1 all the way to a grade 5. Certainly, if the toxicity is very minimal, I may rethink about doing immunotherapy again, especially if there's no good treatment options left. But for those patients who have very high grade pneumonitis or very severe toxicities, I may rethink twice. And in those particular cases, I might think about other options like targeted therapy. If the patients have, for example, a BRAF mutation, I might also think about other options such as clinical trials. The only way to really know or develop newer therapies, particularly for patients who have severe side effects or have progressed on standard immunotherapy, is to do studies that hopefully might be potentially better than what other options we may have left. Some patients who may have, for example, severe toxicities where we can't give more immunotherapy, we may actually consider TIL therapy as an option as well. And then in some rare circumstances, if we absolutely have to, and there's really not much in terms of options left, chemotherapy would be sort of a last resort that I would consider. But I think the most important thing is, not every patient is similar and every patient has, unique side effects, different immunotherapy treatment options. And it's important to weigh the pros and cons of other options to consider when thinking about second, third, fourth line treatment.
If you have basal cell skin cancer, is there a connection to getting melanoma? It's probably a Dr. Wang question.
So not directly. So basal cell is an a common form of skin cancer. For both, yes, being fair complected and having sun exposure are risk factors, but there's no direct correlation between those two.
Dr. Wang questions here. Does a mole that is fading over a short period of time raise suspicion of a regressing melanoma?
Sorry, could you repeat the first part?
Certainly. Does a mole that is fading over a short period of time raise a suspicion of a regressing melanoma?
That's a great question. So a mole can regress over time, meaning that the mole basically gets taken away by your immune system. Often what we see around it is a little white halo, so we call it a halo nevus. Can be normal, especially in kids. We don't tend to worry about those, but in adults, it could be a sign that your immune system is attacking that mole for a reason. Could be a melanoma that's regressing. So possible, but you can't tell for sure just by looking at it.
And then one more, then I'll open it back to the group here. will you talk a bit about how melanoma looks on the skin of color? Are there major differences?
That is another great question. So melanoma, of course, is far more common in white patients compared to patients of other complexions. However, we've seen data really that melanoma in people who are non-white, it tends to have a worse prognosis, and we think that's because it's probably diagnosed later. The types of melanoma that you see are also different. In terms of melanoma, in white patients, we see more of the melanoma that's related to like chronic sun exposure, like superficial spreading melanomas, and so forth, what you tend to think of. In patients who are not white, of course, melanoma itself is rare, but other types of melanoma by proportion are more common. So those would be like acrolentiginous melanomas, so melanomas that we see on the hands, the feet, even within the nail unit. As well as mucosa melanomas, which are rare, but can be a larger proportion of melanomas in people who are not white.
Thank you. Are there other questions from the group here? Yes, in the back.
I'm curious to hear more about genetic testing, and I was wondering, like, when is that recommended for a patient, and what are some of the benefits or drawbacks of doing that?
So genetic testing in the form of like germline testing to see if you have any mutations that predispose you to melanoma. Okay.
If I've already had multiple melanomas at a relatively young age, like, would that be like worth pursuing?
Yeah, that would be a red flag. So that's another great question. It's something that's been debated in terms of whom do we test. One thing that's proposed is something called the rule of twos or the rule of threes. Basically, it's if you've had melanoma and a first degree relative, you sum up those melanomas if it sums up to 2 or more in places where melanoma is relatively rare, so not here, or 3 or more in places where it's more common, such as North America or like Australia. That would be someone to consider testing. And of course, if someone is fairly young and has multiple, that's another potential red flag too.
And then I was curious, like, what are the benefits of doing testing? Like, what does that inform you, or like, what does it mean if you find out that you do in fact have a genetic predisposition?
Yeah. So another great question. So in terms of for yourself, you've already had multiple melanomas. We know that you're high risk, so you're probably going to be following with the dermatologist pretty closely. But in terms of the testing, it does primarily 2 advantages if you want it to get tested. And of course, we talk about this with people. One is some of these melanoma predominant genetic syndromes can predispose you to other types of cancer. So the most common one is a mutation in a gene called CDKN2A, and that can increase your risk for melanoma, but also pancreatic cancer. And so if someone were to found to have this gene, then they can be offered screening for pancreatic cancer, which is not routinely offered to the general population. The other potential benefit, if you will, is we know that some of these genes are autosomal dominant, meaning that it can be passed down to your children. So if someone were to be found to have one of these genes, then their relatives can be tested. So kids, if they got it from a parent, siblings can also be tested as well.
So 2 more questions here from the internet, then we'll take a break. And then again, we have another Q&A at the end. So again, write down any current thoughts or questions. You will have another opportunity. So 2 more questions. I think these both have Dr. Ma's name on them. Do these new treatments only apply to skin lesions, or do they also apply, for example, to melanoma in the adrenal gland?
Yeah, so what I talked about in my lecture were patients who have unresectable, meaning you can't do surgery to remove, particularly stage 3 and 4 melanoma. And so, the presentation for unresectable stage 3 and 4 melanoma can look in many different ways. It doesn't have to necessarily be just confined to the skin. We know that melanoma has the potential to spread to almost any part of the body. Areas we think about like other parts of the skin, lymph nodes, bone, lung, liver, adrenal glands, pancreas, and even in some patients, the brain. And so, the FDA approval and some of the options I mentioned are really applied to patients who generally have that stage 3 or 4 component. So that could be in many different forms of presentation, whether it's with or without skin disease, with or without adrenal gland disease, or with and without brain metastases. And so the treatment option is certainly most likely tailored specifically to the patient based on risk factors, the amount of disease burden, whether or not they have brain metastases or not. Sometimes that actually impacts, for example, what is the most optimal or ideal treatment to select for patients.
And the last question for the morning, for the first morning Q&A, are there any exciting developments in clinical trials for rare forms of melanoma like mucosal or uveal?
The answer is yes. And so, that's another area of interest of mine, particularly in research is, we've done a lot of great studies, particularly for skin melanoma. But what about those like rare subtypes of melanoma? So melanoma that originates in the mucosa or melanoma that originates in the back of the eye. And, I would say sometimes those particular diseases don't get as much love, but, that's an unmet need as well. And so I'm happy to say that, we actually have some studies, not only at Wisconsin, but throughout the United States that are actually primarily trying to investigate new treatments, particularly for those types of disease. And in some cases, those types of rare subtypes of melanoma tend to have a worse prognosis. So a huge, huge unmet need at this time. And right now at the University of Wisconsin, we have studies particularly for uveal melanoma as well as mucosal melanoma as well.
Okay, well, thank you so much to our panel, and we will now take a 15-minute break. There, I think, are still both drinks and snacks in the cafeteria. The restrooms are around the corner for a bio break if needed, and we will reconvene in 15 minutes at 10:45.
Yeah.
Okay, well, as hopefully you saw this morning, for the first half of the session, you were really emphasizing the multidisciplinary nature of this disease and really how we all work together, put our heads together to hopefully come up with better outcomes for our patients. So with that in mind, we'll switch to the second half of the morning. Dr. Adam Burr, assistant professor here at the UW-Madison, will talk about novel radiation therapy and melanoma. Welcome, Adam.
Thank you, Mark. Before I start, thanks to the organizers for inviting me to speak here today, and thank you to all of the patients with melanoma and their families who came out for this great event. And then also just wanted to say how grateful I am as a radiation oncologist to work with such a great group of colleagues and collaborators who really, give radiation a chance to help patients in the ways that it can. And so in terms of our outline, we're going to talk about radiation therapy as a means of local control, either after lymph node surgery, after surgery with positive margins, for patients with disease in the brain, as well as for patients who need palliation or who have a few number of or oligometastatic disease. And then we're going to talk about two novel areas of radiation therapy, and those are radionuclide therapy to augment immunotherapy, as well as combination immunotherapy with radiation. And so before we get into this too far, we need to talk about what radiation is. And so this is the electromagnetic spectrum. And as radiation oncologists, what we really care about are the things on the right, the ionizing radiation or radiation that can break chemical bonds. And right now, UW, we predominantly use X-rays in treatment of melanoma and all other cancers. Come spring of 2026, we're going to have a proton unit, and that will allow us to do some other new and exciting treatments in this context. And so how does radiation work? Radiation works by breaking double-stranded bonds in DNA. And so when a double-strand break occurs, that correlates with lethality to the cancer cell. And so every gray we give causes about 40 of these double-strand breaks per cell. And again, those cells are what lead to loss of information to the cancer cell, and that ultimately leads to it no longer being able to survive. And a common question we get is, why do we do this over multiple fractions? It's awfully inconvenient. Why do we do it over multiple days? It would be much more convenient to do it one day, and that's true. People have thought of that. The answer is that normal cells can actually repair DNA damage caused by these breaks, and cancer cells are very inefficient at doing this. And so by allowing time, we allow normal cells to repair, and cancer cells can't as well. And then the cancer cells see a high dose, but our normal cells see a dose that they can tolerate. And this was probably best illustrated by sterilizing rams in France. And so they noted that when they sterilized them with a single fraction of radiation, that they got a lot of skin reaction and they had a lot of discomfort. But if they did it over 3 days, the rams were able to be sterilized just as well, but they didn't have any toxicity. And so that principle is essentially why we do it in multiple fractions, and that's probably unfortunately a memorable image. And so in terms of what do we have to use for radiation at UW, we really have the full suite of systems that one might want at a major cancer center. And so we have a Varian TrueBeam is our main workhorse machine that is able to do most of the treatments we do. The treatments average 15 to 30 minutes on that machine per site. It has imaging built into it, and so it's able to we're able to align patients very precisely using that. It also has the ability to gate so that we can treat patients at a breath hold if that is advantageous in terms of positioning the tumor. And we can do radiosurgery on that machine. The other machine that we use quite a bit at UW, and I don't know if this is going to play today here, but we use the ViewRay machine quite often as well. It doesn't look like the video is going to play. That's too bad. But the ViewRay is a MRI guided machine, and basically the way that works is it allows two things. One, it allows live tracking of the tumor. So when we're actually treating the tumor, we can physically see it. And that allows us to account for if anything else changes, if bowel changes shape, if the stomach empties, if anything like that happens, we can see it and we can adjust the treatment to make sure it's safe. It also allows us to change the treatment each day. And so as you can imagine, people's internal anatomy changes every day. And most radiation plans can't account for that, but ViewRay can. And that's made treatment much safer for tumors that are in really challenging areas. And so we really use our ViewRay machine, our MRI guided machine to extend the types of radiation that we can deliver. And it's allowed us to deliver treatments in places where that was previously impossible or very unsafe. And so we'll kind of go through one by one and kind of follow through a survey of ways we use radiation in melanoma. We'll start with lymph node surgery, and then we'll work through positive margins, palliation, and then for patients with metastatic disease. And so radiation for lymph node surgery is sort of where it all started and is probably the best known area of radiation in melanoma. And we've known for decades that radiation can reduce the risk of recurrence in patients with high-risk nodal disease following surgery. This was tested in a randomized trial, and high-risk patients were included. There's various factors that make a patient qualify as high risk. Those include, lymph node number, extranodal extension, the location of the disease, and we combine those all together, and if patients are included, then we can consider radiation. And what they found was radiation decreased the rates of recurrence from 36% to 21% if radiation was given versus if it wasn't. It didn't improve overall survival, and it did cause increased rates of fibrosis and lymphedema. And those are side effects that at this point we have more tools to manage than they did when this trial was done. The other big change that has happened since this trial was done is immunotherapy, and specifically that immunotherapy has moved into the neoadjuvant setting or the pre-surgery setting. And while we don't have a tremendous amount of data yet about what we should do with the different responses we see from immunotherapy prior to surgery, it is a source of increased information. And so we can say, well, you're high risk, but all your lymph nodes basically completely, disappeared with immunotherapy, so you don't need radiation. Or, for example, maybe someone's lymph nodes grew during immunotherapy, so immunotherapy is probably not a very effective tool for that patient. Then radiation is even more important. And so I think it's added a lot of information that's helpful. Treatments are typically 5 or 20 treatments. The advantage of 20 treatments is it's slightly, potentially has theoretical slightly lower risk of long-term side effects than 5 treatments, but there's various reasons we'll use both. And one of the tools we've had more recently that's helped reduce toxicity is IMRT. And so on the bottom right is a modern treatment plan compared to kind of an older school treatment plan on top. And the modern treatment plan allows us to push the radiation dose off the skin. You can see that with those different colored lines represent different doses. And so we're able to bring the high dose off the skin, we're able to keep it out of the lungs, and we're able to keep it out of the esophagus. And so we can move the dose around and reduce toxicity with modern techniques. Another place that we use radiation really commonly, and this is similar to Dr. Newman's case earlier, is we use it following surgical resection. And to her point, it's even more common now to have immunotherapy before that resection. So very multidisciplinary. We know from some phase 2 data and some retrospective data that radiation reduces the recurrence after surgeries where there's tumor on the edge of the specimen, that's called a positive margin, by about half. And one of the things that we really focus on in people in this situation is the individual risks and benefits. And so one really valuable forum for that is our melanoma tumor board. I think we have a really excellent melanoma tumor board at UW where Dr. Ma and Dr. Albertini and Dr. Newman and Dr. Wang and all the other physicians who treat melanoma are there, and we discuss all the cases, and you get a really complete view of the situation in that context. And there's obviously different parts of the body that are easier to radiate or safer to radiate than others. And so we have this individual risk and benefit discussion with patients, and then typically we'll treat these positive margin cases with 5 treatments of radiation. And the case shown below is sort of in comparison to the last case where we're treating a very large area. Here we're treating a very small focused area. This was treated after an adrenal melanoma metastasis was resected. This was treated in 5 treatments to try to sterilize a positive margin. And you can see by the colored lines there, that's where the dose was falling off. We were able to push the dose away from the kidney and the bowel. And we were able to do it in 5 treatments, and it has been so far very effective for this patient. And so this is something we can do also similar to Dr. Newman's case in the back. We can do the same thing in a back as we can do in the abdomen. Another area in melanoma that's really important that radiation has a role is to palliate symptoms. And this is a reason a lot of people, and myself included, got into radiation oncology is because we really enjoy this aspect of our field is to reduce pain and suffering from cancer in situations where other potentially more conventional means aren't effective. And so we know, for example, that radiation reduces the pain from bone metastasis by about 2/3. There's some newer data that radiation can actually prevent fractures in patients with cancer that's spread to the bone. Um, and often we'll use this to prevent progression or reverse progression in critical areas. So in a critical weight-bearing bone, or for example, in the bronchus of a lung, or in this case I'm showing here, this was treated on the ViewRay machine. This was a patient with very large liver metastasis who was having significant pain, and we treated that with several courses of palliative radiation. And we were able to avoid enough of the liver to keep good liver function. And we were able to, if you can see in brown there, the stomach, we were able to also avoid and avoid any significant toxicity to the stomach. And each time we did this, the mass shrunk significantly and pain reduced. And this is just an example of one of the things we can do with that ViewRay tool that would be completely impossible otherwise. Another area where where radiation and melanoma have really collided and is really growing is in the oligoprogressive or oligometastatic states. And so what does that mean? And so these are kind of made up radiation oncology words that have spread through a lot of cancer medicine now. But the oligometastatic state was defined as the state between having a lot of metastatic lesions and having localized disease. And some professors in the early 2000s thought that this state has some unique biology, and it's a place where radiation can really intervene. And so in those cases, usually defined as 1 to 5 lesions, you can use radiation to essentially cytoreduce the disease, so to kill 99% of the disease in the body and then leave the rest to immunotherapy potentially. We most oftenly use radiation in the upfront setting when there's a threatening lesion. So we kind of combine the oligometastatic and the palliative in that sense. The other place where it's been really powerful is in oligoprogressive, and what that means is the immunotherapy or the targeted therapy mostly worked, and so it shrunk down 90% of the lesions, and now there's 1 to 5 of them that are still persistent or still growing. And because there isn't an infinite number of lines of therapy, we will often use radiation as a tool to kill those cells that are not responding so that the patient can continue on that line of therapy longer. And that's also been a very effective use of radiation in this setting. We use a technique called SBRT, stereotactic body radiation therapy. All that means is we use high doses of radiation with high precision. And so we're using molds for the body. We're using techniques with radiation that are inhomogeneous so that the dose falls off really quick and that the dose of radiation has a relatively low impact on the surrounding structures, or as low as possible. And in the case example at right, this was a patient with melanoma who'd been on BRAF/MEK inhibitor for about a year, and there was a spot in the lung that had grown over several serial images. And so we decided to ablate that with radiation. And so we did that with 5 treatments over the course of 9 days. And so far that lesion has been well controlled. And we expect with a lung lesion like this, we expect control rates on the order of 80 to 90% from radiation, and ideally closer to 90%. And then finally, the other place that that conventional radiation is really useful is in progressive CNS disease or disease in the brain. And this is where we use radiosurgery. And this is actually not a surgery at all. It's just a high dose radiation, again, delivered very precisely with high gradients. And so the goal here is to treat the metastases in the brain to a very high dose while sparing as much brain as possible. And we do that with arcs of radiation. Our current technique, it takes about 30 minutes for the first lesion to be treated and then about 15 minutes for each additional lesion. By the end of 2025, we think we'll be somewhere in the range of 10 to 20 lesions per hour. So we're looking to dramatically increase our throughput And melanoma patients are one of the main drivers of our need to do that as a cancer center. And again, here we have an up to 90% local control rate. Some cases will need surgery because the lesion's either too large or it's symptomatic, and radiation does not resolve symptomatic lesions very quickly, which is one of its weaknesses here. There's also a risk of necrosis when combined with immunotherapy, and that's something we deal with a lot in melanoma. And one tool we have that's new for that is the fluciclovine PET scan. That's available now on trial at UW, but that's been a very useful tool to help us decide, is something that's changing in the brain necrosis or is it progression? And so that's another new tool that we have. And then typically we do surveillance every 3 to 6 months because again, we want to catch these lesions when they're small so we can do this very focal radiation technique and minimize side effects. Moving on to some novel therapies. This is from the Morris lab. Zach Morris is the other physician that treats melanoma predominantly in the radiation oncology department. He's since become chairman, and so is treating a little bit less melanoma, but is still active in this area, especially on the research side. And so radionuclide therapy is a new area, is in a new area of medicine called theranostics, and this is combining therapeutic and diagnostic agents. And these drugs have two components. They have a drug component that targets whatever cancer cell you're trying for, in this case melanoma. And then it has a radionuclide, which is a radioactive particle that is sort of the business end of the drug that does the killing of the cancer cells. And as you can imagine, there are dozens of different radionuclides that all have different effects and half-lives and things that we can use in treatment of melanoma. And right here, you see a preclinical study of a drug that's in a different clinical trial than what I'm going to talk about today. So I apologize, it's a little confusing, but this was a mouse that was treated with a radionuclide, and you can see that in figure A, it accumulates in the tumor, the drug does. And then in figure H, you can see that these mice that were treated with a combination of immunotherapy and the radionuclide had the lowest level of tumor volume at the end of the 30-day experimental period. In terms of using this now in the clinic, we have an open clinical trial using a drug called VT101. It's a lead radionuclide, which is an alpha emitter. And alpha emitters are really interesting because they are both very potent forms of radiation and because they're very short acting. And this is targeted to the melanocortin receptor. And this radiation, again, is over a couple cell lengths. And the hypothesis here is that similar to a tumor vaccine, the radiation plus the immunotherapy will hopefully help generate a stronger immune response than either one alone. And currently we are enrolling stage 3 and stage 4 patients to get this combination therapy at UW. And again, a really unique opportunity. And then the second clinical trial I wanted to talk about with my remaining time is an injectable immunotherapy combination. And again, this is on the same sort of concept of using radiation as a tool to augment the immune response. We think radiation can do that through killing of tumor cells, which releases antigens, and then we can add to that as well with injectables. And so this injectable that we've acquired is the Army liposomal formulation Q. And so this comes from the U.S. Army. Zach Morris, in addition to running a tremendously successful immunotherapy lab, is also a officer in the Air Force Reserve. And so he met some people at Walter Reed, and they got to talking about immunotherapy, and they talked about this drug. And what it is a vaccine adjuvant that was used in HIV vaccine development. And so basically it makes the T cells more activated to an antigen. And so this is going to open this fall, and it is going to be a study for all skin cancers, not just melanoma. Patients who've been on melanoma or been on immunotherapy for 12 weeks with progression, and then are appropriate to continue with immunotherapy. So they don't have, side effects that would preclude that. And so after enrollment on study, patients will get radiation, again, to try to increase the antigens that are present. We're going to then inject the tumors to further augment the immune system and immune response, and then they will get their immunotherapy the following day, and then that can be repeated up to 2 more times. So a total of 3 times we can give this cycle of therapy. And our hope is that this is going to improve response rates for patients who are not responding to immunotherapy. And we know that the rates of response in that group is about 5%. And so we're hoping to get that up considerably higher with this combination therapy. And so with that, radiation is a versatile tool that we believe we can help a lot of patients with melanoma. And we're very grateful. We're at a cancer center where radiation is used as a common tool in this disease. In its current state, it's very very valuable in local control, and I hopefully showed you that. And then we have clinical trials in development to use this as a systemic agent as well, and we think the future is very bright there. So thank you very much, and look forward to questions.
Thank you. That was a great talk, both about current state of the art and where we're going. And actually, here's one more picture that I'll add to your slides. You'll have to describe it. But anyways, a beautiful picture. So I will speak about lab insights to realize a better tomorrow for melanoma patients. This is my disclosure slide. There are no conflicts related to this presentation. My learning objectives are as follows. Number one, to identify practice-changing insights for treating metastatic melanoma patients. Number two, to appreciate the potential of immune system interventions to improve survival for patients with metastatic melanoma. And number three, to appreciate the essential role of the research laboratory to enhance care for patients with metastatic melanoma. I'll begin by mentioning a commentary that I wrote about 6 years ago for the Journal of Immunotherapy of Cancer. And I use the metaphor of the Age of Enlightenment to describe our current treatments, describing advances that have happened because of our understanding of the immune system and its role against melanoma. I also use the metaphor of the Dark Ages for where we were. This shows survival curves from 2001, but they were really unchanged to 2011. Focus on stage 4, that's metastatic disease. Median or average survival, less than a year. Long-term survival, well less than 10%. Remember this curve when I show you some of the current curves. My strong belief is that laboratory insights have really given us a roadmap, not just for what we've accomplished, but for going forward. I'll first mention the two things that we've accomplished and then give some thoughts about what we need to do going forward. The two steps, one, immune system recognition of melanoma, and number two, immune checkpoint blockade in melanoma. So this cartoon basically summarizes our understanding of how T cells, or immune cells that can fight infection, can also see melanoma as foreign. And again, we humans have evolved as a species to basically live long enough, not die from infections, have kids, and basically our T cells allow us to fight infections, but they can also recognize other things, such as cancer, in a very specific manner. Once this was appreciated, tremendous enthusiasm followed. The immune system is truly an ideal anti-melanoma weapon. You got a diverse attack. There are many different types of so-called immune effector cells. You can have precise targeting by some of these cells, specifically T cells, that recognize very small so-called little peptides presented by HLA molecules. And the big excitement, immunity, once achieved, could potentially last a lifetime. This is shown schematically here. This shows the immune cells in the patient represented by green circles. The melanoma fighting or melanoma reactive T cells are shown in yellow. The good news is the yellow ones are there. The bad news is you can tell by the picture, there's not enough of them. So basically one problem early on was we need more of these melanoma fighting immune cells. That wasn't the end of the problems. The other problem is they're so-called regulatory cells. So in addition to these good guys that you want to go and kill the cancer, there's the bad guys that prevent them from doing their job, so-called regulatory immune cells. There's also what are called suppressive cytokines, so-called hormones of the immune system. These are substances that are released that interfere with how the T cell can reject the tumor. And then finally, immune checkpoints. And this understanding was pivotal. The understanding was that T cells recognize this very specific foreignness in the cancer. That's essential. That's the required bottom line. If they don't recognize it, nothing more can happen, nothing more matters. But that's not the end of the story. There are many so-called immune checkpoints also on the surface. Some, shown in green, make the T cell do its job better. But importantly, many, shown in red, prevent the T cell from doing its job. And for so many years, we understood that T cells could recognize cancer, could work well in the lab, but didn't work in patients or even in many animal models because we didn't understand these negative checkpoints. These negative checkpoints are so-called brakes, the brakes that basically keep the T cell from doing its job. So what were discovered was so-called immune checkpoint blockade. Once we understood, and again, this started in the research lab, that T cells needed to recognize melanoma as foreign. They could recognize melanoma as foreign, but things were turning it off. We understood those things as so-called immune checkpoints that led to development of immune checkpoint inhibitors, which would basically interfere with the brakes. Think of your car on a hill, you want it to get down to the bottom, you cut the brakes, give it a push, hopefully it goes straight, but it'll get down the hill. And what was learned is that these immune cells, once you release the brakes, good things can happen. These immune cells can be much more effective at being able to eradicate and kill the cancer. What was really exciting, and Dr. Ma mentioned this earlier as well, but I'll mention it here because this was really a key and pivotal paper earlier this year, is that these good responses don't just disappear tomorrow. This was the 10-year outcomes of patients who got 2 of these immune checkpoint blockade drugs, nivolumab plus ipilimumab, in advanced melanoma. And again, this is a fairly complicated series of slides. Just look at the top panel and at the top one that's on the top panel, which is patients, advanced melanoma, got ipilimumab and nivolumab. And we're now looking at 10-year outcomes, and not quite 50%, but very, very high. Remember the first slide that I showed you. Those long-term outcomes were around 5%, 8%. Second panel looks at so-called melanoma-specific survival, meaning basically alive, and some of these patients are living so long they die of other things. But basically where cancer is not causing it, and that number is even higher. Another important set of slides from that paper is shown here. And this slide brings hope to so many patients in the clinic now. Everyone, once you have this disease and it's spread, is basically living with that constant fear. When's it going to come back? How long do I have? What do we need to keep on doing? This slide brings hope to that question, to answering that question. And what this shows are patients who were so-called alive and progression-free at 3 years. So again, you take all people that went into that study and they were alive and without the cancer growing at 3 years. And then the question is, what's the chance that they'll be alive in 5 years or 10 years? No more treatment, you just watch them. What's the chance that they'll be doing okay? When you look at the top panel, the overall survival, again, looking at the nivolumab plus ipilimumab, that was in the high 80%, I think 86%. But then the bottom one, melanoma-specific survival in the high 90s. As mentioned earlier, some people can die of heart attacks and other things too, not just cancer. But in the high 90s, these are patients, melanoma-specific survival, who were progression and disease-free at 3 years. The goodness can continue. And in all reality, I think we are curing some of these patients. That's the good news. I think an important point to bring out, and I use this car analogy, is you can also have these immune cells attack normal structures. And this is very sobering, very challenging. But these immune cells, we're taking the brakes off all of these immune cells, and they can attack many organs in the body, colitis, hepatitis, dermatitis, many others. I'll use my car analogy. You take the car on top of the hill, cut the brakes, you want it to go straight down to the bottom. I don't know if many of you have been to San Francisco, but imagine you're on Lombard Street and do that. Not such a good outcome. So again, we got to figure this out better. So I'll now segue and talk about a few programs or research or studies going on in my laboratory to hopefully help us make the next step. The first half of my talk was trying to hopefully convince you that really the lab led the advances in the clinic. But if we're helping long-term half the patients, you can do the math as well as I can. Half the patients still need more help. One is trying to identify so-called predictive biomarkers of response to immune checkpoint blockade. Can we pick out which patients will benefit, which ones will have side effects, which ones we have to look for other treatments? Number two, investigate new strategies to activate more anti-melanoma T cells. We can take the brakes off, but if you've got 2 of the good guys doing the job, you're probably better off if you get 1,000. So ways to maybe get more of those melanoma reactive T cells and then take the brakes off. And then finally, I guess I alluded to this one when I spoke to my response to the funding question earlier, but working with colleagues in the School of Veterinary Medicine, and in all sincerity, trying to help these pet dogs with spontaneous melanoma. Dogs get melanoma spontaneously, like people do. And these are dead dogs if we don't help them. But trying to help these pet dogs, but doing it in a way that's going to inform the field, inform our understanding of the immunobiology, and help me help our patients with melanoma. So I'll start with the dogs. And again, melanoma is the most common oral cancer in pet dogs, but average survival of pet dogs with melanoma is less than, so pet dogs with melanoma that has spread basically is less than 6 months. So if it's spread to other sites, clearly we're in the dark ages if you're a dog. So we're trying to get new treatments to hopefully improve outcomes for our pet dogs, but also trying to do that in a way that's going to inform our care for patients. We're using what's called an immunocytokine. This is a combined molecule, part of which can recognize the tumor, that's shown at the top, part of which can activate the immune cells, that IL-2 in the bottom, and we're injecting that into tumor lesions, trying to basically make the tumor serve like a lamppost, trying to activate more of these immune cells, like Dr. Newman was talking about, the neoadjuvant approach, get more of these cells and then combine it with checkpoint blockade. This shows the design of our recently completed study. These are pet dogs randomized to get 1 of 2 sequences of radiation. As Dr. Burr mentioned, radiation has got reason to combine it with immunotherapy. We weren't sure whether we give 1 dose of radiation or 3 doses. So instead of having 12 patients do this, we're doing this with 12 dogs, trying to figure out which is better and then try to use that knowledge to help us in the clinic. So these pet dogs got 1 of 2 different sequences of radiation. They all got the intralesional immunocytokine. And then we did blood samples and tumor samples and monitored the outcome. And these results were published this past year in terms of our clinical trial results. This shows the dogs in the study. Maybe it's bad politics these days, but we had a very diverse group of participants. If you look at the breeds, Labrador Retriever, Burmese Mountain, Miniature Poodle, Beagle Mix, Great Dane. So again, very diverse patient population. Randomized to either group A, 1 fraction, or group B, 3 fractions. At 30 days, several had stable disease, SD. Some had progressive disease, PD. Some had a partial response, PR. Unfortunately, at 60 days, most had progressive disease. Although one had a complete response, lasted 564 days. One had a partial response, 133 days. So that's the clinical outcome. But again, and actually Dr. David Vail, my colleague in the School of Veterinary Medicine, provided all the clinical care for these dogs. I am not a veterinary oncologist. I get many requests about care for veterinary oncology questions, but I'm not a veterinary oncologist. What we were doing is trying to analyze these biopsy samples to try to figure out what can we learn from these samples to hopefully inform the field and help us better design our next step in patients. We did what's called canine nanostring. This allows us to look at so-called gene expression. And this shows the output from some of those analyses. There's some very detailed slides that if this was a grad student lecture, I'd give much more of those background slides. But we could tell the different cell types, which ones are going up, how are they changing, what's different from arm A and arm B, and try to really understand what's occurring in this tumor that might inform what we want to do and how we want to combine it with immune checkpoint blockade. So in summary from that clinical trial, this immunocytokine could be given in combination with radiotherapy. It's well tolerated, has some anti-tumor activity, not enough, but some. But it can certainly inform our clinical development of this in patients. And the long-term goal is to generate a so-called in situ vaccine. And as Dr. Ma mentioned with his RNA vaccines, really the tumor itself has got all the various things that we want to get rejected. So instead of picking just one or another, which we used to do in the past, we're trying to let the tumor tell us to what the immune cells need to react. And we're trying to make it more so-called immunogenic. So that's the long-term goal of this. So that's half of our laboratory's focus. The other half is what I have called so-called surrogate selection for immunologically relevant cells. So the underlying assumptions of this overall approach is that T cells or these immune cells, if they're going to respond to checkpoint blockade, so again, if these T cells, the way they do their job is by multiplying. They double, 1 goes to 2 to 4 to 8 to 16 to et cetera. They clonally amplify. That's the way T cells do their job, whether it's you're a bacteria or a cancer that wants to get rejected. The other assumption or hypothesis here is that T cells that are doing this expansion are more likely to make a mistake in their cell division. Again, if you make more chances in cell division, you're more likely to make a mistake, a so-called mutation. So this schematic shows the underlying principle here. If you look at the T cells in a patient, most of the T cells in a patient or any of us in this room are so-called resting. We're not all responding to something right now unless we've got some autoimmune disease or other thing that our immune cells are responding. So most are waiting. They're kind of in the wings, so to speak, in the bullpen if you're a baseball fan, but not yet out in the field. A subset of our T cells are dividing, and a subset of those are dividing against the melanoma if you're a melanoma patient. So we're harvesting these lymphocytes, these immune cells, and then growing them for several weeks with conditions that allow us to only pick out the ones that are dividing. We're kind of reducing the size of the haystack for which we got to find the needle, so to speak. We're trying to reduce the number of T cells at which we have to look to figure out which ones are the ones that are really reacting against the melanoma, and then looking at various reactivity readouts. So we've written a recent review of this a couple of years ago, where we kind of characterized the system and described the so-called concept of surrogate selection for immunologically relevant cells. And this is not unique to melanoma. If you look here, many different diseases with an autoimmune pathogenesis, this has actually provided various insights, all the way from multiple sclerosis to rheumatoid arthritis and many others. So again, as a tool to pick out selectively these dividing cells, there's precedence in various autoimmune diseases. And what we were doing is, in the setting of melanoma, really asking the question, will this inform us? Will this let us pick out these informative immune cells? So we've shown that the mutant fraction is higher in these patients than normal controls. We've shown that they're enriched for markers of so-called clonal proliferation. We can pick up these expanding clones. We've shown that they got sequences, the specific sequence that can react against melanoma-associated markers. And we've shown that they can traffic from blood to sites of tumor. So that's all good. And I work closely with individuals in our statistics. Dr. Michael Newton, who's actually chair of statistics, incredibly bright and innovative statistician, did some mathematical modeling of this. And this paper just came out, is actually in press this month. But what he did was mathematically modeled, if we have clones in the body, the gray ones are basically the non-mutants, the normal ones. The rust-colored ones are the mutants. And has shown with a fair amount of equations that I cannot totally understand, but I'm told they're all right, that these mutants are in fact preferentially sampling bigger clones. So we're both getting these dividing cells, plus we're preferentially picking out which clones are the bigger ones in the context of someone with a cancer. So that's all well and good. It was great in establishing the concept, but it's a very cumbersome system. Takes many weeks in the laboratory, and it's hard to get these cells to be able to use them in real time in the clinic. And at the end of the day, I'm a translational researcher with a goal of trying to get a tool to help me in the clinic. So if this concept is right, the mutation doesn't just have to be at this one that we're looking at. There's other mutations. And we're now looking at a different mutation, one in what's called phosphatidyl and acetyl-glycan class A, or PIG-A for short. Normal non-mutant cells have got what are called proteins on the surface, GPI anchored proteins. These mutants have got a mutation that loses that surface protein. And there are reagents, FLAIR, that can stain this surface protein. Shown in the in the panel there, you can see the so-called wild type or normal cells, the majority of them, but the cells that have lost this are the so-called PIGA mutant T cells. Those are the ones we want to find. And we can identify them using what's called flow cytometry, where we can gate the cells, we can sort those cells and look at those double negatives. And in the process of writing a grant with a actually deadline September 2nd to hopefully have this go forward. Again, the goal, trying to use the concepts we've learned with the HBRT system, use a more clinically translatable tool and look at these mutants. And again, is how this could help us. What we plan on doing is saying, can we tell if these in patients, if these mutants have receptors against melanoma, are these the patients for whom we'll see benefit? Many other related questions too. So again, this is an ongoing program of research. The objective is to really get a predictive biomarker of response, try to identify which patients will benefit from these checkpoint blockade treatments. We've got great tools to take off the brakes, but we need better ways of predicting for whom is this going to help and who needs other treatments to either get more of these anti-melanoma cells or look for other treatments. Take-home points. Laboratory insights have improved survival and changed the standard of care for metastatic melanoma patients. I'm old enough to have lived through the dark ages, the first probably 20 years of caring for folks with melanoma. And the most painful years of my life are going to clinic, knowing I had almost nothing to offer besides hope and what is in the laboratory and what might be helpful going forward. So things have happened that have been good, but more good needs to happen. Immune checkpoint blockade can achieve durable responses. And I think we're actually curing some patients with metastatic melanoma, and I would have never said that in the past. We need to improve biomarkers of response. We need to look at combinations with checkpoint blockade. And our pet dogs, our friends that we want to help, can also inform what we're doing in the clinic. I'd like to thank the large number of individuals with whom I'm very appreciative of working. Individuals in my lab, Cindy Zuliger, a very insightful PhD scientist, who all those cartoons I showed you, I didn't make those. Cindy made those. So I guess to the junior folks out here, you need to work with solid individuals. It's really a team effort. Gordy Thompson, a med student in my lab, Will Glass, an undergrad in my lab, but really many collaborators in the Cancer Center, clinical research team, our individuals in the clinic, and our melanoma team, many of whom you've actually seen here today. Financial support. I also have an appointment at the VA where I'm chief of oncology, and I've been fortunate to have a VA merit grant for the canine studies, which ends after next month. But anyways, it's helped for the last 4 years. The Cancer Center providing support. And actually one thing in my early career I never imagined, but the importance of philanthropy. And so Foundation was key in a lot of my early work with surrogate selection and very helpful. The Larry and Sylvia Endowed Trust, very helpful. Tim Eagle Memorial, actually in memory of a deceased patient, which has been very helpful for a lot of the work we're doing. And gifts from Jill and Bob Firemuth and other philanthropic support for melanoma research in my lab. So I've tried to emphasize that there is hope through research. I'm going to now show a video, Guarding Against Cancer 2025, Nancy's story, that emphasized the other part of our multi-D team, and that's the patient. We're in this together. So if we could play that video.
Call this hero snow. Let's go this way. Skiing gives me the sense of freedom. And it's a great thing because Mike and I do it together. Badger ball. Badger ball. It's how we met. It's what we do. So we're trained as EMTs on skis. It really shows you how fragile life is from a different perspective. So 23 years ago, I was diagnosed with breast cancer, and I went through some treatment, and then 8 years later, I was diagnosed again. And then in 2023, I was diagnosed with metastatic malignant melanoma. I'm so glad to have Carbone here in Madison, where I can be treated. I call it the Pac-Man. So you get this infusion and the Pac-Man goes like this and it eats up those bad cells.
Well, I think Nancy's an amazing person and Nancy's an amazing patient. And the treatment she's getting is really a very new way of giving immunotherapy. I've been caring for patients with melanoma for about 3 decades. And for probably the first almost 20 years, there were almost no treatments that were effective. With these newer treatments, I'd say perhaps about 40% of patients are now doing well for many years, and a good fraction of those patients can be cured. Our body has immune cells to help us fight infection and other types of foreignness. Our immune cells can also recognize cancer. What was learned is that there's ways to keep the immune system turned on so the cancer can no longer turn off the immune system.
The more research, the more we learn. I can't even imagine what we're going to know 5 years from now. I hope I'm around to see it, but there's so many things that are happening that are really exciting. And, if you ever doubt that, ask if you can have a lab tour at UW Carbone Cancer Center. It's pretty cool to see what they're doing behind the scenes.
Work in my lab is actually looking at immune cells for various patients. We try to figure out, can we identify which treatments are working best? Can we figure out which immune cells are ones we most want to activate and work with? We're looking at giving treatments, actually injections into the tumor, to try to get the tumor to better activate a rejection response that could then be paired with this immunotherapy treatment and hopefully be more effective.
We know that we want to give back to Carbone for all they've done for me and for Mike, my family. And one way we thought we could do this is to, we started out with a big fun picnic party out here at our house 15 years ago. It became from a party, it became sort of a mission. And it starts with each of us, one person, one family, making that difference. The high yield, high risk experiments, those will never happen unless we have seed money, seed dollars, enlarged by philanthropy. The imagination is the limit. And there are an unbelievable amount of insights that just need the opportunity to be tested. It's a whole nother ballgame now. I find myself a positive person. You look pretty good skin today, I thought. Yeah. You just have to stay positive and think about what you have to look forward to. Wake up, you're going to find something great on the next day, and you just have to keep doing that. I will never give up. I will never, ever give up.
So we're all in this together, and actually Nancy's in the audience. Nancy, would you stand up, please? Thank you for being you. Anne, you've got Anne has got a presentation now, and then we'll have a Q&A session afterwards.
Thank you. Thank you, Dr. Albertini. Thank you to all of our panelists today. Thank you, Nancy, for sharing your story with us. I am so proud to be here and speak with you for just a moment about AMIT melanoma. For those of you who are not familiar with our foundation, we were founded 20 years ago by Valerie Guild. Her daughter, Charlie, was diagnosed with melanoma at the tender age of 25. And 20 years ago, as so aptly has been described, was a totally different time in melanoma. And unfortunately, she did not respond to the only FDA-approved treatment that was available at that time, which was IL-2. So after she passed away, Val was determined to make this experience count and make a difference in the future for other people who would be diagnosed with melanoma. And so she founded AMIT Melanoma with two purposes. The first is to find a cure for melanoma. And so the first thing that she did was to found the International Melanoma Working Group. It's a by invitation meeting twice a year by researchers that are looking into treatment and research in melanoma so that they have the opportunity, researchers from all over the world have an opportunity to communicate and collaborate with one another to move melanoma treatment forward. And the other thing that they specifically asked as a course of these meetings was that she would develop tissue banks where they could collect fresh frozen tissue from the primary tumors. It's taken a long time to develop those. We have 5 across the United States. We've now collected almost 250 samples. So we're almost to the point now where we would be able to release those to researchers so that they could start using that information that they've garnered from this tissue to help move melanoma treatment research. And so we're very proud of that work, and we continue, and it is our primary focus to find a cure for melanoma. But in the meantime, we want to support those people who are, living with melanoma, who are going through a melanoma treatment journey. And so I want to tell you what that looks like and what we do. We're a patient advocacy organization, and education is a big part of what we do. That education largely comes through our website. Everything that I'm going to talk about now is available at no cost to the public. By far, the most frequently visited pages on our website have to do with the various stages of melanoma, the different types of melanoma, the related treatment options that are available for people who've been diagnosed with melanoma, the side effects that they might expect, side effect management guides that we have on our website, and a very large section that is on melanoma clinical trials. In addition to that, we have a PA. Her name is Melissa Wilson. She's worked alongside of AIM for several years now, and she is an oncology PA that works with Dr. John Kirkwood at UPMC Hillman's Cancer Center. And what she wants to do is to answer questions that you didn't get a chance to ask in clinic. So by a show of hands, how many of you have left that precious time with your oncologist, walked to the car, put your hand on the door handle and gone, darn, I forgot to ask my question, right? Yeah, that happens, and we know that. Now, it isn't Melissa's desire to change your plan of care. What she wants to do is help you to understand things like, now, why am I having a PET scan instead of an MRI, right? Or there's a term perhaps that the doctor used over and over again, and you didn't understand what that term meant. So we have a form online that you can fill out so that you can ask Melissa these questions so that she can make sure we feel that well-informed patients make better choices for their care. So we want to make sure that you understand what your plan of care is, and we're not, supplanting Melissa with your care team, but rather this is additional information so that you're as well-informed as possible. After many years of providing that service for AIM, then Melissa suggested that she do a series of webinars because she was getting the same questions again and again. What is BRAF? I've been diagnosed with melanoma. Now what do I do? So she has done a webinar series we call it From the Clinic to the Living Room, where she explains some of these most commonly asked questions. And I highly suggest that you check those out, because she has a real way of speaking language for people who are not, don't have a clinical background, as most of us do not. So there's the clinical, the physical aspect of being diagnosed with melanoma. And then we are well aware that there's also the emotional impact of being diagnosed with melanoma. So we want to address that as well. And in doing that, there are a few things I want to make sure that you're aware of. One, we have a podcast that's called Beyond the Clinic, and our podcast director's name is Samantha Siegel. She herself is a cancer survivor, and she is the director, the KP's new director of survivorship in San Francisco, cancer survivorship. And as Dr. Albertini was saying, what a wonderful day it is that KP has a director of survivorship for their melanoma program. Dr. Siegel would like to invite you to embrace vitality from the moment of diagnosis. And so join us on that on our podcast to hear her philosophy behind we understand that a cancer diagnosis is an emotional roller coaster, but she wants you to embrace everything that made your life good before you heard that you have cancer. how to integrate everything into your life and not let cancer become its driving force. In addition to that, we have a one-to-one peer program called Peer Connect, where we match survivors, people who have gone through their melanoma journey. We know that being diagnosed with skin cancer can be somewhat isolating, even though you are surrounded by you have a great care team, you have wonderful family, wonderful friends, and yet you could feel like perhaps that you're walking this journey alone. And so adding somebody to your circle of trust, somebody that you can talk to about the things that you're thinking and feeling, can be very valuable. If you are on the other side of your melanoma journey and you would like to become a mentor, we can always use new mentors in our program as well. And then the last thing I want to tell you about is we want to care for the caregivers too. I was talking with somebody today that said she's not a caregiver. What she does is it's her job to do all the research and do all the remembering. Well, that's a caregiver, right? And we want you to take care of yourself too. So we have an entire section of our website dedicated to our caregivers. So if you have any questions about AMIT melanoma, I am the website navigator, and if I can help you find anything on there, then please reach out to me and please talk to me. And there are two things very quickly before we get to our questions that I want to bring to your attention. Inside your patient packet today, I put a paper survey. AMIT Melanoma does 10 of these. We co-host 10 melanoma symposiums a year. These are very, very important resources. We would like your opinion on this symposium, the information that was presented today. I know that that Dr. Albertini and team would like to know how you feel we addressed your concerns and the things that you were hoping to hear. This helps us to make our symposiums better and better. Somebody is going to ask me, and so I'm going to tell you, what happens to all the information that was disseminated today? Well, what will happen is immediately following this symposium, it will be available on AMIT Melanoma's YouTube page. So if you go to YouTube and you type in AMIT Melanoma, you will find a link that will take you to this entire symposium, including all of the questions and answers from today. But then in addition to that, we will take each of the individual presentations, divide them by topic, and put them onto our website so that you could, watch those again, or perhaps share them with other people that are trying to understand what your treatment journey is and what options you have before you. And then lastly, this didn't make it into your packet, but I have some of these with me, and I want to ask you, let AMIT Melanoma be in relationship with us. Let us serve you. And so I have a form here that invites you to join our mailing list. The value of that is that every time ASCO, when Dr. Ma was talking about the new research that comes out of ASCO, what we do is we have a director of medical education, and she takes that information and she translates it from clinical researcher to everyday person. And she will release that and tell you the exciting new research that has come as a part of these large medical conferences. We also have, we send out information about, we do 10 melanoma conferences a year. So we will tell you when those are coming out. We'll tell you when Melissa releases new webinars. So all this information that we want to give to you, this is a way for you to have access to that through our organization. So if you are interested in being, in contact with us and having access to that information, and if you'll fill this out, then we will add you to our mailing list. Okay, and so that is all. And with that, I'm going to turn the podium back over to Dr. Albertini, and we will answer our final questions.
Okay, I'd like to invite all of our presenters who are here up to the podium, and then any of us. And Dr. Newman had a prior commitment, so she actually needs to leave early. If there's any questions for her, I can bring those to her. But the rest of us will be here, and you can ask questions of any of us. So.
Be here today. She was diagnosed with stage 4 cancer in her lungs and her kidneys due to the amazing care that she received from Dr. Ma and everyone at Carbone, she's cancer-free for 1 year. What someone mentioned earlier, every morning you wake up and think, is today the day it's coming back? And it's a concern that we all have, I suppose. So my question is there any correlation between how long you've been cancer-free versus your chances of it redeveloping? Or is it just kind of a random thing?
Well, first of all, I just want to say congratulations, and I'm very happy to hear that. And, you know, I say as a medical oncologist, these are not unheard of stories where we see patients who get treated with immunotherapy, that they're getting these long-lasting disease control. And dare I say it, you know, we may be curing some of these patients, right? You know, I think what we've learned over the years is that, you know, and again, immunotherapy is still relatively new as a cancer treatment. You know, we still need more years and decades of research to understand the outcomes of patients who are being treated with these drugs, not only the efficacy, but also the side effects. But, you know, to just provide some light or some better understanding of what we're seeing is, you know, as we see patients who, for example, get great disease control, the further you go out, the chance of this coming back or even progressing becomes even lower. So the many more years you go out, or, you know, with in terms of disease control, the better the outcome. And again, we're still trying to develop these registries. You know, cancer centers across the whole country, the world, are just trying to understand what are the long-term outcomes. And as we get some more of that data, I think we're excited to see what we're, you know, hopefully hoping to see more of in the future of what patients are doing and how they're doing with these particular therapies.
Well, I will also try to answer some questions, but I guess I should probably MC up here too. So anyways, next question, sorry.
Yeah, I'll actually answer maybe a question that was, I think, posed by one of the audience members online. And one in particular was actually by a very astute audience member. But on one of my presentation slides, there was where I had talked a little bit about using the individualized neoantigen therapy or the mRNA vaccine in combination with immunotherapy. And what they noticed on the particular graph was that it looks like there may be at some point some sort of overlap between the comparison of patients who got immunotherapy versus the mRNA vaccine plus immunotherapy. And if that's correct, you know, what does that sort of mean? And what's the overall benefit of actually doing two particular treatments versus just one? So just to kind of better understand the figure itself, you know, towards the tail end of the curve, you know, we know that some of those patients who have relatively entered the study early on have not entered into that phase. And so the distinction between recurrent, between those who got both drugs, you know, the mRNA vaccine plus immunotherapy versus the immunotherapy, the curve separation may not have actually, we're not at that point of mature data to distinguish the both of them. But I will say though, you know, as we speak about this, right, what I had presented was more of the earlier phase of the study. What we're anticipating more of right now is what is going to be the long-term outcome for the phase 3 trial, which just recently completed accrual, and what the long-term outcome is going to be for those patients. And as I mentioned, with vaccine therapy, our hope is that we want to see things like prevention of recurrence. But that's also more than just that as well. We also want to see a more patient-centered outcome, which includes things like overall survival. And as of right now, you know, what we're trying to better understand is, you know, does immunotherapy after surgery, has that shown improvement in overall survival? But that's still an area that's of ongoing debate and an area of ongoing research right now.
Right there, question in the middle.
Yeah, hi. Thank you all for your contribution. I appreciate all the information I've gotten. I have two questions. Hopefully I can remember both of them. And they sort of focus on the preventative side of this disease. So the first question was, Dr. Wang, you spoke about these sort of little iPhone devices. Was kind of curious, is that going to have any value being in the hands of the person rather than the clinic?
That's a great question because I think right now we have a lot of technologies that are being developed, and I think the technologies are maybe outpacing our knowledge of how to use them a little bit. So in terms of devices, so that little iPhone device, it's actually um, it's a computer program that's built into the iPhone using the iPhone camera to take those photos. So that's currently something that's designed to be used in clinics. In fact, we're hoping to bring that platform to UW as part of a pilot study. There are so that little dermatoscope that attaches to the iPhone was designed to be something that can be manufactured fairly cheaply and be available to patients. Um, that is also a matter of research in terms of how useful that is. There are actually groups that have given these devices to patients and then taught people how to take photos on their iPhone and use that as a way of being able to reach a dermatologist quickly if they have something that's changing. So definitely an area that's being explored, and definitely more research is needed into how best to use these technologies.
And here are two questions, I think, from the same person. I'll mention them both right now. For class 2 uveal melanoma, are there any adjuvant therapies that are recommended or being developed? And number 2, are there immunotherapies that are effective for metastatic uveal melanoma? So Dr. Ma, do you want to comment on those?
Yeah, that's a good question. I mean, I think today we primarily talked quite a bit primarily on cutaneous melanoma. And, as I mentioned, there's a variety of different subtypes of melanoma that exist out there, one of which is called uveal melanoma, which by in itself, I think I would consider almost a disease entity in its own. It has a different and unique biology that in some cases don't really respond as well to some of the treatment options we had discussed earlier today for particularly unresectable stage 3 and 4 melanoma. So getting back to the question about uveal melanoma or ocular melanoma, and again, just to remind the audience, this is melanoma that exists primarily in the back of the eye and is typically associated with a poor prognosis, and not as much research has been done because it's considered to be a very rare type of melanoma. And so for uveal melanoma, we can categorize the disease into two particular types of risks, or classes, as we call them. They can be either a class 1 or a class 2. And class 2 is considered to be one of those higher risk uveal melanomas and has a higher propensity and higher likelihood of metastasizing, meaning spreading or going somewhere else after successful treatment of the disease in the eye. And so a question that was posed was, are there any adjuvant treatments? So treatment that is given after successful radiation or surgery. And as of right now, there is actually no FDA-approved option at this point. But I will mention that there are some studies being conducted and a lot of presentations and studies that have been published so far that have shown that there may be some success. But unfortunately, there has to be some sort of rigorous sort of studies that need to validate the use of it. Because as you can imagine, when we're thinking about trying to get drugs approved, we not only want to make sure that it's not only safe, but also effective, right? Is it going to prevent recurrence, but also is it going to provide meaningful survival benefit for patients? And as of right now, for class 2 uveal melanomas, that's still an area of ongoing research is how do we help prevent recurrence for those patients who are considered very high risk? And then I guess Dr. Albertini, if you can remind me about the second
Sure.
question
The
again.
second was, are there any immunotherapies that are effective for metastatic uveal melanoma?
Yeah, so as we kind of mentioned earlier about some of the immune checkpoint blockades like ipilimumab and nivolumab, a very commonly used regimen for this disease, but the response rate and the efficacy is not as good as we would like it to for the skin melanomas that are stage 3 or 4. Now, there are other immunotherapy treatments that are approved for this disease, in particular, a medication called tebentafusp. It's also known as Kimtrac in its brand name. But what we call that medication, it's a bispecific T-cell engager. It's a very unique type of immunotherapy treatment, first in its class for this particular disease and for almost all solid cancers. But the way it works is it essentially helps bind and bring together the cancer cell and the immune cells together to more effectively treat uveal melanoma. And as of right now, that treatment is only FDA approved for stage 4 or advanced stage uveal melanoma. And unfortunately, the efficacy of that treatment is not as great as we would like it to. And certainly there's ongoing studies right now to help improve the success of this treatment, because not only is it given once a week that patients take for as long as the treatment works, but it is associated with side effects. And the response rate, so as I mentioned earlier, that 30% threshold in terms of a meaningful response is only about 10%. And so as you can imagine, for a very rare type of disease like this, we're trying to develop newer and better treatment options for those patients.
I guess a question that I'll give to Dr. Burr, what is the difference between no evidence of disease and cancer-free?
I think that's a largely semantic distinction. No evidence of disease and cancer-free, but I think no evidence of disease could also be that you're kind of in an early stage and we're still observing and still watching versus, you know, maybe cancer-free farther out. But I don't think there wasn't an intentional distinction there.
If my tumor biopsy occurred in October of 2023, how long will my biopsy be available for future needs, such as mRNA vaccine? And I think that is probably going to change over time, but at this point, with this still being a research use, would need to be obtained prospectively. One can get mRNA signals from archival and prior saved tissue, but at this point, we really have no approved mechanism to use that in a translatable therapeutic manner. But some of those signals in terms of mRNA can be obtained in older tissue. So again, I think that's something that, you know, as technology evolves, but at this point, it would be a prospective clinical trial. But Dr. Ma, do you want to add any more to that answer?
Yeah, no, I agree. So, you know, as of right now, the idea of this mRNA vaccine, as I talked about, it's still being studied in a prospective fashion. And so, you know, as of right now, it's difficult to say if we could use some of that tissue that was previously excised and stored somewhere, if we could utilize that for the mRNA vaccine. But as of right now, the way the vaccine has been developed is it's prospectively collected relatively fresh, you know, after surgery, and using that in order to develop the vaccine for the patients. So, you know, I think this is an area where we're still trying to better understand, you know, can we use older tissue to develop those? But right now, until we get, you know, true FDA approval, results of the phase 3 study, much of that is much more speculation and something that we need to learn more about and look forward to.
So we have about 2 or 3 more minutes. I'll first open it up to the audience here. Any questions from the audience first? You get first dibs because you showed up this morning in person. Oh, sorry, in the back? Well, as probably the one on our panel who's charged with making that distinction, Alex, our dermatologist, will answer your question.
So yes, they can.
Maybe just repeat the question for our online audience.
So the question is, can skin cancers hide in the tattoos? So they can, because often the way we see melanomas is that they appear dark because they have more melanin. Not all melanomas appear that way. Some of them can lack pigment or be amelanotic. But tattoos can certainly make it challenging to see if there's something changing within the tattoo. We have actually diagnosed patients who have had melanomas within the tattoos.
Okay, I'll be like the bartender. Last call for the audience first. Okay.
Yeah, I'll try to repeat that question, which is a question was posed about, how reliable, for example, is ctDNA, particularly for patients who, for example, may be on treatment, and how are we using that sort of information, for example, to determine, maybe the frequency of scans. I think this kind of question was kind of similar to what was kind of discussed earlier in our previous Q&A, which is this exciting new technology of ctDNA, which is the ability to detect microscopic amounts of melanoma DNA in the blood. And so as of right now, the technology is still continuing to evolve. And I will say that if patients who are participating in ctDNA monitoring, whether it's for surveillance or as a means for treatment monitoring, that's still an area of ongoing research. And it's something that I've been very heavily involved with as a researcher as well, is can we use this sort of information to reliably help, not only help with patients with surveillance, but also help inform treatment management. But as of right now, I would say ctDNA, while it has been helpful for some patients, it is not the most sensitive tool. There have been some experiences where I have also seen personally where patients who have developed melanoma recurrence despite having an undetectable ctDNA level. Now, this technology is continuing to evolve, and we're starting to see that it's becoming hopefully more sensitive over time. But an area that still needs to be further investigated is how do we use that information to change management? Should we be using that, for example, to de-escalate, decrease the frequency of scans, for example, provide better reassurance for patients? And I have to say that that's still an area at this time that's still being currently investigated at this point. And so right now, I'm currently working with many institutions across the country about trying to validate the use of this test and how we can actually use this type of information to actually inform treatment management. But one of the other things I also want to mention as an oncologist, when I bring up the idea of using ctDNA, I also caution that we still need to take it with a grain of salt. We also know that by having this information, it can provoke a lot of anxiety. It is still not yet considered the gold standard in terms of treatment monitoring. Imaging, physical examination, surveillance still remains the gold standard in terms of monitoring for recurrence, and ctDNA right now still remains an area of ongoing research.
Yeah, and I would like to add my 100% concurrence to that answer. I think it's a very exciting technology that may in fact help inform in the future. And Dr. Ma is really helping to provide some data to help inform this going forward. But at this point, it's still not yet a tool that can be used as a standard of care treatment. So any more questions from the audience? Any more from online?
Yes, I actually have a couple more that were just posed from online. So one in particular was if biopsies were taken years ago of a melanoma tumor, how long are those biopsies viable to create TIL? So that's actually a great question because, TIL is now FDA approved for the past year, but what I will say is that based on the current technology of TIL, the ideal situation is that if a patient is a candidate for TIL, you actually have to have a fresh tumor biopsy. So using archival or tumor tissue that is stored somewhere else, whether it's a few months or years ago, is not something we can isolate to develop the current TIL therapy workflow. So that was a good question. And then one other question is maybe something for Dr. Burr is, I don't want to start any conflicts between the UW colleagues, but which is more effective and least toxic, radiation therapy or immunotherapy? So I'd love to hear Dr. Burr's thoughts on that.
So I think that's a good question, but I think in terms of radiation in melanoma doesn't really exist without immunotherapy and without the advances in systemic therapy. While radiation has advanced a lot and changed a lot, many of the technologies that we have were available in the dark ages, like Dr. Albertini talked about, and they didn't make huge impacts on the disease. It's only in the context of immunotherapy and of targeted therapy that radiation can I think really start to make meaningful difference. And so I don't think it's necessarily a one or the other. In terms of the toxicities, I think they're really interestingly different. Immunotherapy can have a wide variety of unpredictable toxicities, and I think that's one of the challenges of it. Radiation typically has predictable toxicities, and so when we look at a site that we're treating, we can predict pretty accurately what the risk is of any given toxicity. And while there are some rare ones that we don't always get, most of the time it's very stereotypical and predictable, and we can talk with you as a patient about, well, this is what we would expect. And if those toxicities aren't acceptable risks, we can dial that back and we can take less risk. There's kind of an infinite amount of customization and personalization that we can do with radiation. And so so I would say that they're different, and radiation is certainly a more predictable level of toxicity because the body's response to it is just more stereotyped, and we're aiming it at a very precise location.
Were there any more online questions? So in bringing the session to a close, I would like to thank the panelists. I would like to thank all of you in person, and I would like to thank our online viewers as well. Clearly, a lot's happened in melanoma. A lot still needs to happen. The emotion of hope is a real one, founded in fact. Progress has happened. More progress is needed. We will accomplish this together. Thank you for being here, again, both in person and virtually. The session is now closed.